Good afternoon. Welcome to the National Clinical Care Commission virtual meeting.
Audio recording for this meeting has begun.
My name is Jennifer Gillison with Kaufman Associates, and I'll be the facilitator today. I'd like to start by explaining a little bit about the webinar interface. You should all see a PowerPoint slide in the middle of the screen, and there is a Q&A box to the right. You can enter any questions, comments, or technical issues into that Q&A box. All phone lines have been muted. If you need technical assistance during the meeting, please type the issue into the Q&A box, and one of our techs will respond to you. Please note that this meeting is being recorded, and I'd like to turn it over now to the chair, Bill Herman.
Good afternoon. It's my pleasure to welcome you to this 10th meeting of the National Clinical Care Commission. Our designated federal officer, Dr. Clydette Powell, is not able to join us today due to another urgent matter. So the designated federal officer joining us is James Berger. Jim is the Senior Blood and Tissue Policy Advisor to the Assistant Secretary of Health in the Office of Infectious Diseases and HIV/AIDS Policy, as well as the designated federal officer of the Advisory Committee on Blood and Tissue Safety and Availability and the Tick-Borne Disease Working Group. I'll turn it over to Jim now to welcome you and to conduct the roll call. Jim?
Thank you, Bill. Yes, I'm honored to welcome you to the National Clinical Care Commission February 17, 2021 Federal Advisory Committee virtual meeting. With that, I'll start out to the official business to do the roll call. When I say your name, please indicate that you are present for record keeping. With that, I'll start out with Bill Herman.
Present.
Pat Shoemaker.
Here.
Howard Tracer. I have a note that Howard will be joining us at 1:30, so I'll check back with that. Moving on to Barry Marks.
Present.
Next is Naomi Fukagawa.
Present.
Donald Shell.
Present.
William Chong.
Present.
Aaron Lopata. Repeat, Aaron Lopata.
I am present.
Thank you.
Aaron Lopata is present. I'm sorry.
Thank you. Moving on, Ann Bullock.
Present.
Barbara Linder.
Present.
Captain Samuel Wu.
Present.
Paul Conlon.
Present.
Ayatondi Silkun.
Present.
Carol Greenlee.
Present.
David Dortschultz.
Strogatz, present.
Thanks, David. Dean Schillinger.
Present.
Ellen Leak. Repeat, Ellen Leak. Moving on to Jasmine Gonzalvo. Repeat, Jasmine Gonzalvo. Moving on to John Boltrey.
Present.
Oh, this is Jasmine. Jasmine's here.
Yeah. Okay, Jasmine, got you down. Thank you. Meredith Hawkins.
Present.
Shannon Heidzik.
I'm present.
Thank you. Terry Bolin.
Present.
William Cook. Repeat, William Cook. Is there anybody whose name has since joined since I did the roll call that I might have missed? Okay, if not, we do have a quorum. We can proceed with business. With that, I'll turn it back over to you, Bill.
Great. Thank you, Jim. May I have the next slide, please? And again. So as you're all aware, the National Clinical Care Commission is a federal advisory committee established by the Congress in 2017. The commission was established by the Secretary of Health and Human Services to evaluate and make recommendations regarding improvements to the coordination and leveraging of programs within the Department of Health and Human Services and other federal agencies related to awareness and clinical care for diabetes. Next slide. The Commission has been charged with 5 duties. First, to make recommendations to the Secretary and Congress regarding federal programs that focus on preventing and reducing the incidence of diabetes. Second, current activities and gaps in providing integrated high-quality care. Third, the improvement in and improved coordination of federal education and awareness activities, which may include the utilization of new and existing technologies. Next slide. Fourth, methods for outreach and dissemination of education and awareness materials for healthcare professionals and the public. And finally, opportunities for consolidation of inappropriately overlapping or duplicative federal programs. Next slide. The activities of the National Clinical Care Commission have evolved or revolved around the work of three subcommittees addressing treatment and complications of diabetes, prevention in the targeted population, so high-risk individuals with prediabetes, and efforts for diabetes prevention in the general population. There's also a small work group that's been addressing health system level interventions to improve diabetes prevention and treatment. Each of these subcommittees and the work group are also focusing on social determinants of health, health equity, and identifying research needs. As in the past, most of today's meeting will focus on the presentation and discussion of updated and new recommendations from each of the subcommittees. We'll also be talking a bit about some preliminary recommendations from the work group addressing health system level interventions, and we will have some public comments as well. So at this point, I'll turn it over to the first subcommittee report from the Treatment and Complications Subcommittee, and that's Paul Conlon and Carol Greenlee are the co-chairs. So Paul and Carol, over to you.
Thank you, Dr. Herman. This is Dr. Conlon. May I have the next slide, please? So I have the pleasure of providing a report of the Treatments and Complications Subcommittee. My colleagues on the committee are shown here on this slide, including a number of individuals who donate their time from the private sector as special government employees, and some individuals like myself who represent government agencies to the Commission and specifically to this subcommittee. May I have the next slide, please? In the course of the intervening period since the last Commission meeting, our subcommittee has remained quite active in collecting information from both federal as well as non-federal stakeholders and key contacts. Shown in this slide is actually a glimpse into some of the work that's been ongoing, including meetings with individuals from the federal sector, representatives from the VA, from AHRQ, from the Centers for Disease Control and Prevention, and the Federal Communications Commission have been solicited for their input, as well as major private sector groups have also been contacted, including representatives from the American Diabetes Association, the American Association of Medical Colleges, University of Pennsylvania, and members of the subcommittee have also participated in webinars and other digital media issued by the American Medical Association, as well as other sources of information. Next slide, please. I'm now going to turn the ensuing portion of the presentation over to my co-chair, Dr. Greenlee, who's going to talk about the subcommittee's focus and then present our first draft recommendation.
Thank you, Paul. So just to frame how we are framing our work is we recognize that probably the biggest gap facing patients with diabetes or people with diabetes is the gap between resources that are already available and the patient getting optimal use of those resources to improve their health outcomes and their lives. And so our priority has been to focus on those items or those elements that will, what we call, move the needle the most, will affect the most people, make the biggest change for them to provide the biggest benefit. Next slide. To do that, we sort of grouped and regrouped and came up with 4 priority topic areas and then divided into small groups to work on those. Those are diabetes, self-management, education and support, team-based care, diabetes technology, and virtual care. And across all of those, we've been focused on reducing health disparities so that we can optimize individualized care and improve outcomes. Next slide. Along those lines, one of our first draft recommendations was around health equity, and I will need to open my slides to read that. Sorry, I don't have it memorized. So our recommendation, can you go back to the health equity slide?
Yes. So can we please make sure that you're not moving the slide, you're moving it for everyone?
I actually didn't touch the slide.
I know.
I said,
I know.
oh, okay.
I know.
Okay. So our recommendation was that for the federal agencies, health equity should be a component of any new or revised policy related to diabetes, meaning that for any new or revised policy related to diabetes, the relevant federal agency would consider and evaluate the impact on health disparities. We recognize that the agencies were collecting data, or some of them, such as CMS, were collecting data on disparities in things like amputations and dialysis, but not on the impact of their own policies and programs. So we recommended that federal agencies ensure the collection of appropriate and relevant data and use such data to assess and improve the impact of their policies and or regulations on health disparities among persons with diabetes. And this is because as we were evaluating these programs, we recognized the impact on worsening disparities that some of these programs resulted in. So next slide. With the new administration on February 20th, wait a second, that's supposed to be January 20th, I'm so sorry, an executive order on advancing racial equity and support for underserved communities through the federal government was signed into action. And this executive order is creating a domestic policy council to coordinate efforts to embed equity principles, policies, and approaches across the federal government. Along with that, this executive order recognized that many federal agencies are not collecting the type of data set they need to even recognize when their policies and programs are worsening disparities. So they've established an equitable data working group to help the agencies collect that data, with the note that a first step to promoting equity in government action is to gather the data necessary to inform that effort. Next slide. And they're asking each, okay, next slide. Each agency within 200 days of the executive order being signed, which was January 20th, not February 20th, that the head of the agency selects a certain of the agency's programs and policies for review, does the review, and provides a report reflecting on any potential barriers that underserved communities and or individuals
might face in enrolling in or accessing the benefits and services in these federal programs, or that communities might face in procuring and contracting different opportunities which may apply to some of our diabetes programs, and any new policies and regulations or guidance documents that are necessary to rectify these problems. Next slide. So our recommendation after discussing this in subcommittee is that we retain our draft recommendation. An executive order is not law. It's hard to imagine this one being struck down in the future, but we would like to acknowledge the executive order and call out the need for these these assessments to assess and address equity in diabetes-related policies and programs, and provide specific examples of policies and programs and the relevant data that could be collected to inform on equity or on the disparities created by those policies and programs. And an example comes from the CDC paper that showed that for the CMS DSMT programs, that many of the rural economically disadvantaged counties lack DSMT programs. And so monitoring that would be an example of what we could specify in our recommendation. Next slide. So I'm hoping Ellen will get on, but we will move to virtual care. That's one of our topics that we feel will help bridge the gap for people living with diabetes. It obviously goes well beyond people living with diabetes. It has an impact on preventing diabetes, both as a general population and among high-risk individuals. Next slide.
Carol, did you want to take any discussion on the equity point?
Thank you, Paul. Go back. I should do that. Thank you. Any comments or need for clarity, input on how we've adjusted this recommendation to continue it despite the executive order, but specify specific diabetes data and programs?
Carol, this is Dean Schillinger. Thank you very much for this recommendation. As you know, health disparities can result from or associated with race, ethnicity, and socioeconomic status, and the two are obviously correlated at times. Are you specifically limiting the request to health disparities associated with race, ethnicity, or does it also include socioeconomic status, health insurance, those kinds of things? And if it is the former, I think the recommendations need to be specific in that regard. Thanks.
Well, we just have started to collect them, but the one example that I gave here, obviously there's probably some race and ethnicity data that underlies some of these economically disadvantaged rural counties, but this was actually the CDC paper just looked at where DSMT programs are and found that they weren't in the more economically challenged or disadvantaged counties. So it is more than just race and ethnicity, but we just need to look across different programs that impact people with diabetes and suggest that they be evaluated by this new council that was created by this executive order.
Right, but isn't the new council specifically around racial and ethnic disparities?
No, I'm sorry. I took that slide out. It was, I can send everybody access to this executive order, but it includes racial and ethnic minority populations, but it also includes rural, age-related populations that might be disadvantaged, economically disadvantaged. It's much broader. What the executive order listed as underserved and areas of disparities is much broader than just racial and ethnicity minorities.
And it sounds like you agree with that.
Pardon?
And it sounds like you're on board with that the Commission would recommend taking a global perspective on disparities.
Absolutely, yeah. Because not all of the policies and programs that we've identified are disadvantaging people based on their race or ethnicity. It may be like here, it's more geographic or economic.
Yeah, so I guess, Bill, sorry to interrupt, but my recommendation around the recommendation was in the language of the recommendation, it currently just says health disparities, and I can't remember if the Domestic Policy Council was mentioned in the recommendation, but there probably is a need to be specific around what that means, maybe reference the Domestic Policy Council's scope, but also not be beholden to the Domestic Policy Council, which may not be here in 4 years. You know what I mean? So
yeah.
just a little thing around specificity there.
Yeah, that's why we wanted to retain. We didn't want to say, oh, this takes care of our draft recommendation. We don't need to recommend it anymore because it's already taken care of by this executive order. We felt it's very important to retain this recommendation and then specify for people with diabetes, these programs, these policies, and this data needs to be left. That was clear. Any more comments or questions? Okay, go to the next slide, please, and now we'll go on to virtual care. And as I said before, it extends beyond just helping people with diabetes, close the gap. It goes clear to the whole scope of what we're working on. At our last full commission meeting, we presented our draft recommendations around e-consultations. One of them had some questions and confusion around it, and we have clarified that. Just to clarify again, that e-consultations are not teledoc. They are clinician to clinician. If you could go back a slide, please. Clinician to clinician consultations where a primary care clinician asks a question of a specialty care clinician, and it does not require an in-person visit unless that specialty care clinician feels like it's too complex and then can say, I need to see this person in person. And so these e-consultations can be very helpful to people with diabetes who often require input from multiple different specialists. It can reduce delay and fragmentation for the patient. It can reduce transportation, economic, missing work type of burden for the patient, and it can help disseminate and update knowledge between specialty care and primary care through the educational role of these e-consultations. So it would be very, very beneficial to people with diabetes and their healthcare providers to have e-consultations more widely used and to be sustained so that they're not felt to be abused. And that requires program integrity around the use of these codes. Next slide. The two codes are the 99451 that can be billed by a specialty care clinician who has received any consultation as long as it exceeds 5 minutes in work. Now, the specialty care clinician could put in 5 hours of work and they will get no more reimbursement. Keep in mind that when a primary care clinician sends a referral to a specialty care clinician, that typically they have had they have not been able to bill for that service in any way. But we and other people working on this have felt that with an e-consultation, all of the work needs to be done by the primary care team, and so that there should be a way for them to be able to bill. So the 99452 code allows the primary care practice to bill, but only for the time spent preparing and submitting the clinical question. And based on a complex formula, this must total 16 to 30 minutes. Currently, almost no primary care teams are devoting that amount of time to generating a question, and so almost no primary care are billing for this service. As far as the work involved in any consultation, it actually is generated once the recommendations come back from specialty care, and the benefit of that e-consult does not accrue until that recommendation has returned to the primary care clinician and they can implement it as appropriate with the patient. So by expanding the 99452 code to not be limited just to the time of preparing and submitting the clinical question, but to allow it to include the work time of reviewing the recommendations from specialty care in their response to the e-consult and then implementing that, it would allow enough time for primary care to build that code, and it would provide benefit which supports the program integrity. The big pushback to this modification is right now that's an awkward time to bill. It's easier to bill when you send the referral. AAMC is working with academic medical centers around the country, and they indicate that if this recommendation is enacted, that they can help codify and develop the process for the billing when the recommendations are received and acted upon. So this is a clarification of a recommendation we made last time. I hope the explanation makes sense, but it is open now for any further clarification, questions, or input. That mean none. John Boltry, you had in particular had some issues with this recommendation. Does this clarify it any better for you?
Yes, I appreciate you asking, and I don't see the wording that I was concerned about previously, so thank you for making that clarification.
Good. Any other input? Okay. Next slide.
Hey, Carol.
Yeah.
Carol, hi. It's Ellen. I've now been able to join.
Okay. When we get to the Bridging the Digital Gap, I will hand it off to you. Thanks so much. I'm glad you're here. Okay, next slide. So as we all know that we've been in a public health emergency, and prior to the public health emergency, telehealth was limited to rural areas that were considered medical shortage areas, and the patients had to go to an originating site to use the equipment at that particular medical facility. With the public health emergency, that geographic restriction and originating site restriction were waived, so that people across the whole nation were able to get telehealth services, and they could do it from their home or college dorm. They didn't have to go to a medical facility. Prior to the public health emergency, telehealth, Medicare telehealth rates were about 30% less than in-person office rates, and with the public health emergency, they were increased to parity with in-person office rates. Before the emergency, only established patients could be billed for telehealth, and with the public health emergency, it allowed also for new patients, which allowed for some consultations for patients with specialists. Also, the public health emergency put a waiver on the use of equipment that allowed a more liberal use of different kinds of digital equipment, including smartphones. And because many people did not have access to broadband, cellular networks, devices to use those, or the digital literacy required to use them, eventually into the public health emergency, CMS allowed for audio-only televisits with payment equivalent to in-person established patient office visits. Prior to the public health emergency, federally qualified health centers and rural health clinics could not utilize telehealth to service their patients and provide care, and that the waiver allowed them to do that, and also allowed diabetes education programs to be a covered telehealth service. Next slide. So what's going to happen after the public health emergency ends? Well, as part of CMS's authority in the 2021 final rule for Medicare fee schedule, they have permanently liberated the type of equipment that can be used, including smartphones. So that will continue after the emergency. But CMS does not believe that it has the statutory authority to extend the waivers for geographic and originating site restrictions, audio only, federally qualified health center and rural health center use of telehealth, or DSME, DSMT programs use of telehealth. And this will have to be updated by congressional action through the legislation, which is updating Section 1834 of the Social Security Act. Currently, many stakeholders are working on this, talking to Congress about this, and we anticipate that at least some of these may be made permanent by Congress. And so we are watching that now. And that's what I mean by maybe resolved. It's hard to imagine going back to those geographic and originating site restrictions, as those were very outdated to begin with. Next slide. However, there are a lot of policymakers, including MedPAC, that have, go back one, that have raised questions about the potential for overuse and even abuse of the telehealth services, especially the way that they are allowed to be billed at this time. And one opinion piece felt that the likely path forward is to expand telemedicine coverage beyond what was available prior to the pandemic, but not at the current level of expansion, and that the continued use needs to be based on value. Therefore, it might be limited to certain patient populations, types of televisit modalities, or certain conditions, like living in a rural community, et cetera. That the determination of who gets to use telehealth should be based on robust evidence, which does not exist. Now, because of the public health emergency, there's a lot more data on telehealth than we've ever had before. It's in the process of being collected by many federal agencies, as well as academic and private and commercial agencies, but we don't have that data yet, and we don't have it analyzed. So it's hard to know which populations, modalities, and conditions warrant being continued. They say maybe on estimated use or overuse might be a determinant. Telephone or audio only is important from an equity perspective, but is really ripe for overuse. In addition, remote patient monitoring and asynchronous messaging, such as portal messages back and forth, if everybody starts charging for every single interaction, that's going to generate a lot more cost without necessarily associated benefit. But from our standpoint, the ability to use telehealth when it's appropriate, audio when it's appropriate, and remote patient monitoring when appropriate without worrying about abuse, but just benefit to the patient, would be by encouraging it as part of population-based payment model, specifically a pilot around diabetes. Next slide. So considerations for continuation of telehealth for people with diabetes. Many people with diabetes really benefited from access to televisits during the public health emergency with care continuity, education and support, and reduced burden. For example, people with diabetes on insulin pump therapies are normally required to have an in-person visit every 3 months to get their ongoing pump supplies. And when some of those visits could be provided by telehealth, it was especially beneficial to them, and they didn't have interruption of care. So it would benefit people with diabetes to be able to continue the use of telehealth, including receipt of diabetes support and self-management education. So our subcommittee feels like we really need to gather the evidence to make the case for diabetes to be one of those conditions or populations of people that would benefit from continued use of televisits. Again, the data that we have is not extensive, but it does indicate that televisits are safe and effective, and diabetes education is effective when provided virtually. Diabetes is more common in communities with low internet connectivity, with lower income, with lower education, and higher age. And these are the same communities that are less likely to have connectivity or to be able to afford the devices or to have digital literacy. And so it's important to continue audio only for equity reasons until we get a better fix for the digital divide. So, and again, we feel that use of telehealth to benefit people with diabetes could be more optimized through a value-based care and pay model. Next slide. Additionally, we will be continuing to watch the geographic and can you go back one? Originating site waivers to see if they are acted on by Congress and if those waivers are made permanent to remove those restrictions. Also, the waivers around federally qualified health centers and rural health centers and the diabetes self-management training programs. We believe that we would like to see those waivers made permanent, and we think that perhaps the audio-only visits might fall under this executive order for advancing racial equity and support for underserved communities, and we will watch to see how that plays out and base our draft recommendations as the months go on whether these are already attended to or whether we need to continue advocate for them. And I will stop here with the recommendations that we want to build the case that people with diabetes should be one of the populations allowed to continue teleservices, as well as these for comment and input or clarification.
Carol, this is Bill Herman. That's actually very nice. One of the issues that the work group has been discussing relates to moving away from fee-for-service to bundled payments or to care management fees provided to provider groups for care. That would let providers use telehealth pretty much as they saw appropriate for patient management and get away from the whole idea of the charges, the individual service charges, and the potential for abuse. So I think some of the discussions may want to focus on, I think as you have to some degree, bundled payments or incorporating care management fees for patients with diabetes that can be used at the discretion of the providers.
We have had, yes, I agree, population-based payments, but we have had huge pushback against bundled payment fees. It needs to be more whole person care. We've had pushback from clinicians and from many, many others that bundled payment would not be appropriate for diabetes, meaning aid only to cure the diabetes. And people come into diabetes with all of the predisposing factors that we talk about in general population prevention subgroup, many other comorbidities, et cetera. So I agree 100% with the capitation health base and not, itemizing every time you answer a portal message, et cetera. But I would say that what we've learned, because we went in think bundled payment, but every place we turn, that people with diabetes are benefited more by a comprehensive approach that allows us to look more than just the diabetes. So I'll just throw that out.
Maybe partially the definition of bundled payments. I was thinking more holistically, actually, not just for carving out diabetes, but for patient populations.
I would imagine that you are. Somebody keeps moving the slides. Can you go to Ellen's ready to present, and her slide is the...
Yes. So
Carol, I had a... This is John Boltry.
Go ahead. I'm sorry. Go ahead.
In the last bullet there, you have discontinuing payment for these services would exacerbate inequities in health care, particularly for those who lack access to audio video capable devices. And what we've seen in our rural areas is two things. One is not having high-speed internet at all to support that, even if they do, and also not being able to afford a high-speed internet. So I might just add on a few words, in addition to access to audio-video capable devices, access to high-speed internet.
Yeah, and we recognize all of that, and Ellen's going to get into some of that, but we recognize it everywhere from access to the broadband and cellular networks to the devices, not just access, but affordability to be able to subscribe to the services, and then even understanding how to utilize the service. So thank you for that, and I'll be sure to clarify that and hand off to Ellen at this point.
Thank you, Carol. And John, thanks for your question. We will get into that a little more. Apologies for my late arrival. We're in the middle of an ice storm in Mississippi, and I sometimes tell my colleagues on treatment complications that I live the digital divide down here. But as we turn toward really the definition, for our purposes, the digital divide, we're looking at the intersection of connectivity and health, specifically diabetes and the impact on underserved communities. So let me move to the next slide and give you an overview, the background, and some of the summary points that we'd like to bring out from our informant calls. First of all, no one on this in this meeting needs to be convinced that diabetes is more common in underserved populations. And as Carol said, often the same population lacks digital connectivity, which is crucial, especially around infrastructure for telehealth, remote learning, remote work, employment opportunities, and job training. We had some very, really good informant calls with the FCC, and one could say that broadband access, especially as we look back over the last year, is really a gateway for other social needs, which makes it a super determinant of health. You know, the research has shown that the FCC has done that there is a link between digital access and the health of a community, including health metrics like diabetes, obesity, physician shortages. But the data also shows that digital adoption, and by this I mean an internet subscription, that this has an even more powerful effect on health. And we'll get into some graphics and look at some mapping from the model. More complex than the pipes and fibers of access, sometimes adoption has really gotten less attention. But it is really a crucial issue to explore and remedy in bridging the digital divide. Next slide, please. So in an informant call, we met with a task force at the FCC called Connect to Health. It was an initiative created back in 2016 to develop a cross-cutting, data-driven model that maps broadband and health in America. And most importantly, it has really revealed the impact of that intersection between broadband access and adoption on health. The program, or the map, which in our call, the informant call, it's more than a map. It's a tool. It's an enabler. It's an interactive platform from both a macro, a state and regional level, down to a micro level, down to the county or even the census block, showing how broadband availability and adoption overlay with health metrics. As we said, diabetes, obesity, physician availability, sick days, hospitalizations that could have been prevented. It also includes a third range of characteristics, demographic filters, urban, rural, density of population, age, employment, unemployment, and education. And the vision is very simple: everyone connected to the people, services, and information they need to get well and stay healthy. So let me give you a summary of the findings from this research. As we said, most counties with a shortage of primary care physicians are also the ones that are least likely to be connected. 40 to 60% don't have basic internet access. Preventable hospitalizations are 1.5 times in least connected counties. And these counties have some of the highest rates of chronic disease. Unfortunately, obesity is 25%, diabetes is 41% higher than the national average in counties where 60% of households really lack broadband. Diabetes prevalence is higher when connectivity is lower. Conversely, connectivity goes up, prevalence goes down. And as we said over and again, internet adoption has the greatest correlation to improved health outcomes. So let's move to the next slide and look at a graph that shows this correlation between health outcomes and broadband and adoption. As you can tell, I know the print is small, but on the left, the green bar represents adoption, and the yellow bar represents broadband access. The first thing that Connect to Health modeled was diabetes prevalence across changing levels of access and then adoption. The next point, that even control for education, income, age, separately and together, you can still see this relationship. And it goes on that adoption appears to have a great correlation to improved outcomes. It's easier to see if you look at a map. Let's move to the next slide. This map helps you visualize broadband access down to the county levels. And let me give you a bit of a cheat sheet here. The yellow is bad and the royal blue is good. But across these counties, and this is a map that shows where more than 50% of the population is rural. And you can see the prevalence of diabetes greater than the national average in these counties with limited access. If we move to the next slide, you can see the same variables, but this slide depicts urban areas. So far more availability and adoption in urban areas, and you can see the difference, which really points to the widening gap between rural and urban broadband usage. So let's move to a final slide, which is called a double burden, a double whammy in counties where they have high rates of diabetes prevalence with low connectivity. In fact, this double burden county map shows that more than half of U.S. counties, or a population of 36 million, have high burdens of diabetes as well as a greater need for broadband connectivity. 60% of rural America lives in a double burden county versus 5% of urban counties in double burden. Rural counties are 10 times as likely as their urban counterparts to experience primary care physician shortage. Really sobering statistics. And so we put forward, next slide, for your consideration as we formulate recommendations, that there is a great need to accelerate broadband access and to understand the barriers to adoption in order to improve health and health outcomes and reduce disparities for those living with diabetes. So I'll pause there and actually pass the baton back to Carol for some additional considerations around clinical practice and digital connectivity.
Thank you, Ellen. Next slide, please. So as we're considering possible draft recommendations around digital connectivity, I wanted to share a concept that the Connect to Health team shared with us, that we shouldn't just use virtual connectivity to replace and do the same that we can do when we're in person. We should be able to do more virtually and sort of surround the patient or the person with an ecosystem of services wherever and whenever they need it. And this would be especially beneficial to people with diabetes. So to be able to help improve connectivity and its impact for people with diabetes, efforts to improve broadband connectivity need to be accelerated via a variety of collaborative means, and we are still in process. We know besides FCC, USDA, and others in the federal agencies impact this. FCC in particular needs to focus more broadly on connectivity to include adoption as well as their current focus on improving access. And there's a need for more research on data to better understand the correlation of connectivity with improved health. For example, understanding why diabetes prevalence goes down when connectivity goes up. And it probably relates to that super determinative health, but it needs to be investigated. And also, I think we're thinking about a possible CME, or suggesting a possible CMMI initiative to pilot such a virtual care ecosystem for people with diabetes, pulling in the use of team-based care to provide that whole person approach that we just talked about. And interestingly, there was just a paper shared with us by Dean Schillinger on how when community health workers utilize virtual care in addition to in-person care, that diabetes outcomes were improved and A1Cs went down. So we'll stop there for questions for Ellen or any of the rest of us.
Carol, there is a question from Dean in the chat. What is the FCC's exact or potential role in supporting broadband access?
I can't answer that at this point. Their exact Liz.
You know, I will say in this
Naomi?
stimulus I was just going to say in the stimulus package there is $3.2 billion for the FCC in emergency broadband benefits, and that's broken down in some interesting ways around rural broadband. But the FCC, you know, doesn't lay fiber, obviously. They're auctioning the airwaves, and so it's a public-private partnership, I think, at its best. But, Dean, we probably need to give you a more concise answer.
Hi, this is Naomi. I had a different question. Can you hear me?
Yes, proceed.
We can.
Oh, great. Yes, thank you. So I thought those were very compelling pieces of evidence that it's very, very important to gather data that would support the kind of recommendations that you're making. But what's not clear to me is how would we go about collecting that robust data, given that one could envision multiple agencies doing the same thing and against cross purposes, with cross purposes, should I say. Have you thought about what the recommendation would be from a research perspective?
Naomi, are you talking about harvesting the telehealth data that has been rolling in with the public health emergency, or the data that Connect to Health generated on population and community health based on connectivity, or both?
Both aspects.
I think you're very wise to say, I mean, there's so many people collecting this data now, and how can that be better coordinated and integrated and not duplicated? And so that gives us, at least across federal agencies, something to investigate more. I don't know that we can direct all the different, like the AMAs collecting data, and even some of the diabetes organizations are collecting data. But across federal agencies, we could suggest that those are coordinated. Our meeting with the CDC suggested that they do have coordinated interagency groups, and I will actually have to look that up and get back about that. because it's not in my head right now. But they did talk about they're even working with like the American Telemedicine Association and other people trying to integrate how they collect all this evidence and analyze it. So, I mean, there is an effort. So thanks for pointing that out, that we need to keep our focus on that as well.
Right. And especially since, you know, part of the USDA's mission is to improve rural communities and connectivity. And perhaps that would be something that you could leverage to, you know, not just lay the fiber, as Ellen said, but really to try to increase adoption and, you know, potentially work together in collecting the information that you need. Thank you.
Yeah, this is Paul Conlon. Thank you, Naomi, for that comment. And this subgroup is obviously still working to develop what we'll present as formal draft recommendations, so that input is valuable. I did want to try to keep the group somewhat on time for our presentation. So what I'm going to do is suggest that we now turn to Sherry Boland, who's going to present the results of the work group that she's been leading on team-based care. And Sherry, please go ahead.
Sure. And what is our time frame? Like, do I need to try and cut this a little bit shorter?
Yeah, we actually only have about 10 more minutes for this session, but we started a little late, so if you could do it in 20, that would be great, or 15.
Okay, I'll aim for 10. Great. So this is just we had some discussion earlier today and also since our last meeting around team-based care and just how we frame this around whole person care. So just a little bit of background is that most people with diabetes have multiple other conditions as well as many other competing demands and stressors, and recognizing that the recommended self-care or self-management required for type 2 diabetes generally adds about 2 hours of work per day, and it can be much more for type 1 diabetes. So I think that you know, those self-care and that self-management really lead to can lead to diabetes distress, which impairs health outcomes, and as I mentioned, sort of that coexisting conditions or comorbidities, social factors, and other stressors really add complexity to caring for patients and for patients to have, and people with diabetes to manage their condition. And so we're looking at improving diabetes quality of life and health outcomes and looking at it through a lens of whole person care and not really a siloed approach, and really feel that that's best optimized through team-based care, and that the team-based care approach is really vital for effective patient-centered care and value-based care models, and has been shown multiple times to be effective to improve the diabetes health outcomes. And we've mentioned before, really, to optimize team-based care, it's going to be really important to have appropriate workforce that's trained and available, as well as sustainable reimbursement, and have that effectively integrated into the workflow of care. So this, we've talked about before, that team-based care really addresses those barriers to optimize individualized diabetes care and outcomes and promotes the whole person, with a focus on some of these 4 bullets that are particularly relevant, including unmet social needs, behavioral health issues, including diabetes distress, competing demands, complexity and polypharmacy, and trust and effective communication between healthcare teams and patients. And I really mentioned on the last slide sort of the things needed to implement or optimize team-based care, but there are also key barriers to team-based care as well. And so we've found sort of healthcare workforce shortages, especially in disadvantaged and underserved settings, that reimbursement is an issue in particular for integrating community health workers, clinical pharmacists, and behavioral health and coordination among specialists in primary care, and then implementation, support, and strategies, because even if you have the appropriate workforce and you have the appropriate reimbursement, if you're not integrated in using team-based care, you may need implementation, support, and strategies. I don't know, maybe somebody's moving the slides, so I apologize. I keep trying to move it to where I want to be. All right, so the workforce training is not, so I'm going to dive into those 3 areas, and we, just as a reminder for folks, so one was workforce training. We talked about this last time, but just as a brief update, that most of the dollars for workforce training goes through the graduate medical education and is primarily paid as CMS GME payments, which are about $10 billion of those $12 billion that go to teaching hospitals that often have limits on the number of trainees for a specific teaching hospital. And the training program types are generally selected by the health system as opposed to potentially what's needed in the community for that group. And it's not chosen by CMS. And then HRSA assesses and assists with workforce training, but the dollar amount that is given to them is limited. It's less, much less than the, $10 billion that goes to CMS, and then the restrictions on who gets trained under those opportunities. So there's different regulatory and statutory limitations on the different programs that may hinder sort of team-based care and interprofessional training, although HRSA does an excellent job of trying to meet the needs of the current workforce. And then the second is really just that it's been noted in many governmental reports that there's a need for global assessment of healthcare workforce needs, not just specific subgroups such as physicians or nurses, but really what is the entire healthcare workforce need as we think about team-based care. There's not standardized data collection efforts to show the impact of training on workforce needs, and then, globally. And then there's typically agencies that are providing training programs are not aligned with the HRSA reported workforce needs. So those were some of the issues as a reminder that we had for healthcare workforce. So we've made some changes in edits to the recommendations that we presented last time based on some additional stakeholder meetings. So that's what these are here. So to improve diabetes care and outcomes, we have 3 recommendations right now. We recommend that HHS establish a mechanism to routinely assess and identify all healthcare workforce needs and not just specific subgroups, and ensure that training program funding is directed to meet those needs. And it was recommended that we seat this within HHS as it may be a more viable way to move that forward as opposed to a workforce commission that might be outside of HHS. The second bullet, I'll read all 3 of these and then I'll stop for feedback. The second one is really evaluating the HRSA training programs to identify where there are regulatory or statutory barriers or limitations that may need to be modified to allow flexibility to meet the needs of team-based care and new care models as part of training. And then the goal of that is really that once those are evaluated, that then they could be potentially modified or changed to make it meet the needs of where we are today. And then the third bullet was still needs a little bit of work, and I'm hoping that we can get some additional information from HRSA about what is the demand for the different training programs, versus the what they're able to meet in terms of the need. And so we continue or increase the exemplary programs which support training healthcare professionals within medical shortage areas, such as the HRSA National Health Services Corps, to provide available healthcare workforce and team-based care for underserved populations. So I think we'll be able to tweak that a bit more once we have a better understanding of what the demand versus the need, so that we can essentially we'd like to be able to say that we meet the need by enhancing support for these different training programs. So I'm going to stop there, just and then I'll move on to the next set.
So Sherry, there is a comment from Dean that says that the recommendation should be to increase HRSA training programs, not just continue. The need versus capacity mismatch is huge.
Yeah, so we're looking just for some data so we can support. I think that sort of supports the comment I was just talking about.
Yeah, so and he says,
go ahead.
Sorry, he says the recommendation could be increased to fill the population level needs.
Great. Any other comments about these before I move to the next set? Okay. So the second is focused more, around that issue of reimbursement that, and in particular focused on some of the three categories where we felt that there was could have the greatest impact on diabetes outcomes, and also would have the greatest impact for the areas that may have the greatest need in terms of reimbursement and in terms of being able to implement that in team-based care. So one is, sort of we've talked about before, community health workers having no real fee-for-service codes, and they're often grant-funded, and so integrating and sustaining community health workers in models of care has been challenging. Clinical pharmacists can bill under different agreements, but typically they're at pretty low codes, and it doesn't typically cover their costs. And then the behavioral health specialists have different coding depending on the specialist, but also if you're thinking about collaborative care models where they're potentially not doing face-to-face time but helping with behavioral health outcomes, how do we appropriately reimburse? So, and in general, most of our stakeholders really have talked about value-based care and payment models would allow for better integration and sustainability of team-based care, and that's been our main focus. I don't know if it's me when I hit it. Sorry. So our recommendation around this is pretty similar. We've tweaked it a little bit to say CMS and CMMI should identify and implement mechanisms for use of community health workers, clinical pharmacists, and integrated or collaborative behavioral health in existing and future value-based models of care. And that's really our main recommendation around this. The second piece, I've said some of this background before, and just in the interest of time, I think I'm just going to jump to our recommendations because I think we're limited on time. But that we made some specific recommendations around community health workers as it relates to Medicaid reimbursement, because it's more around clarifying some of the existing guidance that's out there that could just make it easier for community health workers to be used within Medicaid framework. And so this is really just saying that CMS should build on their 2013 final rule where they already allow community health workers to serve as part of providing preventive service care, but really expanding that so that community health workers can be included as a qualified provider type to address a broader array of services, so social, behavioral, and economic support services as part of the allowable preventive services. And states have already done that with state plan amendments, but if CMS were able to clarify that through a director's letter to states, it would make it more clear about how they can be used and enhance uptake within the states. And then just also further clarification that CHW qualifications should focus on life experience, interpersonal skills, and community membership as opposed to formal education or clinical training. And if we do that, it really would require that CHW services be delivered in accordance with evidence-informed standards for community health worker programs, such as those being developed by the NCQA. And so those are supposed to come out this month, so we may be able to tweak some of our wording around that once we see those. And then the last is really that CMS should develop specific guidance to affirm that Medicaid funding is available for community health worker services that address social determinants of health. And that builds off of what they've already provided states guidance around for addressing social determinants of health in their recent roadmap, but it would more specifically allow for those broader range of services. So I think those are for reimbursement. Any comments on the prior value-based payment or the community health worker reimbursement? Okay. And then lastly, we're just talking about implementation. And so last time we talked about trying to look at this a little bit more and what our recommendations would be. And we have two recommendations around implementation, and then a third one that relates to the research end of this to help with implementation. And you could, sometimes there's a gray line there. But the first one is really expanding the ability of ARC through primary care extension programs and other mechanisms to provide technical assistance to medical practices to implement team-based care, including use of community health workers, clinical pharmacists, and integration of behavioral health services. And the second is really CDC is already providing states information on how to integrate the community health workers into what sort of that whole person approach and not just preventive services. But I think if it was done in coordination with changes at CMS, that could, then CMS could really expand that work to help states integrate the utilization of community health workers. And so that's what this second bullet is around. And I think I'm going to move to show you the last recommendation because I think it ties into that. But just that translation of evidence into care often takes a long time, and that implementation science research, especially if they're large-scale implementation studies, can really promote accelerated uptake of team-based care models and help implement these team-based care models. And so one of the things, and looking at sort of implementation science research, at least from just comparing ARC, CDC, and NIH, ARC and CDC, who do a lot of translational research, have much less funding compared to NIH research, which is primarily basic science, even though they do have an implementation science piece as well. And so our recommendation is really around enhancing funding for implementation research within and to specific federal agencies for team-based care, in particular as it relates to reducing barriers to and improving care for people with diabetes. One of the questions I had was around, wow, how did it go all the way back? I really didn't touch it. So the one question I'm having about this particular one, and you guys may have further feedback, is whether it's all of these agencies or just some. But that's any comments about this recommendation or the two on the prior page that we just talked about. And I don't know if other groups are making research-based recommendations, so we may end up combining some of these depending on what other groups are doing when we get to the larger report. I'll turn it back over. I'm done with this portion. I'll turn it back over.
Okay, Dr. Herman, that concludes the report of the Treatment and Complications Subcommittee. I'd like to thank the committee members for all of their hard work. It's a work in progress, but it wouldn't be possible without everyone's effort.
Great. Thank you very much, Paul, and thanks to all of the speakers as well. We'll turn it over now to John Boltry and Howard Tracer. We're running about 10 minutes behind, but I think we're okay, so please go ahead. So John and Howard, are you up?
Can you hear me?
Yes, now I can.
Okay, thank you, Bill. Appreciate that. Howard, if you're there, hello everybody, and you can go to the next slide. These are the special government employees that are part of this subcommittee based on prevention targeted population. Next slide, please. And these are the regular government employees that are part of this committee. What we're going to do is we're going to start off with some background that Howard is going to present, and then we will go into our 4 focus areas. So Howard, are you ready to present on the background?
Yes. Can everybody hear me?
Yes.
Okay, great. I wasn't sure. I dialed in a bit late, so thank you, John, for that introduction. This is just the overview of the subcommittee's 4 focus areas. So screening and diagnosis for prediabetes, improve access and utilization to effective type 2 diabetes prevention interventions, sustainability of type 2 prevention, diabetes prevention over the longer term, and then research needs developing new and more effective preventive strategies for type 1 and type 2 diabetes. Next slide, please. So as John said, I wanted to start with a rationale for lifestyle intervention for diabetes prevention. It's a large part of what our subcommittee is focusing on, and I know that some questions have come up in the commission about this issue. So just to give this background and rationale for lifestyle intervention. So the next 6 slides will go over that. So first, the risk of progression from prediabetes to diabetes is significant. It's about 5 to 10% of people each year with prediabetes develop diabetes, although that conversion rate varies based on different studies and different populations you look at. And prediabetes, back please. I see others have had this issue with the slides. I didn't. Thank you. And then, of course, the definition of prediabetes can vary from study to study, but I'll touch on all those points. So one meta-analysis found annualized incidence rates of progression to diabetes in patients with isolated impaired glucose tolerance about 4 to 6%, isolated impaired fasting glucose of 6 to 9%, and patients who have both impaired fasting glucose and impaired glucose tolerance are a higher risk population, and that meta-analysis found conversion rates of about 15 to 19%. So again, varies depending on the risk of the patient, but not insubstantial even in patients who I think clinicians might commonly identify as having prediabetes, that is by doing just a fasting glucose, and doing a glucose tolerance test would be much less common in practice. If you look at a slightly higher risk population, the risk of developing diabetes was about 11% a year in both the Norfolk Diabetes Prevention Study, which was done in the UK, and the Diabetes Prevention Program Outcome Study, which was a longer-term follow-up of patients in the Diabetes Prevention Program. Again, looking at just impaired fasting glucose in the U.S. multi-ethnic study of atherosclerosis, so pretty well-studied cohort, that was about 6% a year. And then in the Japanese population-based study, you can see those numbers between 7 and 9% a year. Next slide, please. And we know that we've got an effective way of preventing diabetes in people with prediabetes. And the good thing about lifestyle intervention is that it's really effective in a broad range of adults with prediabetes. So the DPP, which you've heard a lot about, and that enrolled a higher risk population who had both impaired fasting glucose and impaired glucose tolerance. Lifestyle intervention reduced the incidence of diabetes by 58%. In a more recent UK study, the Norfolk Diabetes Prevention Study, and you can see the enrollment criteria there, fasting hyperglycemia, but a bit above what we would consider the starting point of impaired fasting glucose, so above 110, or participants could also have hyperglycemia in the 100 to 109 range, as well as an elevated A1C. Lifestyle intervention in that study reduced the incidence of diabetes by 43%. But there are a lot of other studies that looked at persons with prediabetes who were defined differently, or you might consider a lower risk population. They had only impaired fasting glucose, or only impaired glucose tolerance, or an elevated A1C. And those have also, there's several of those studies that have demonstrated the effectiveness of lifestyle interventions. So however you define diabetes, it looks like this intervention can be effective. In secondary analyses of the DPP, the lifestyle intervention was effective in all the people who were enrolled in that study, and that would be regardless of age, so younger or older. Sex didn't seem to affect effectiveness. Race, ethnicity, BMI, so whether someone was overweight or just barely overweight or obese, or baseline risk of progression to diabetes, so that would include those persons who are at lower baseline risk of progression. Lifestyle intervention was effective in all those groups or subgroups of people with prediabetes. And I'll contrast that with metformin, which definitely has a role in diabetes prevention, but metformin in the DPP was less effective or not effective in older persons compared to younger persons, people with a lower BMI compared to people who were more obese, and those at lower baseline risk of progression. Next slide, please. Okay. The next important point is that these lifestyle interventions that are effective in preventing diabetes are also cost-effective, and as you'll see at the end, quite cost-effective. So as context, in the United States, it's felt that interventions that cost between $50,000, I should say less than $50,000 to $100,000 per quality-adjusted life year. So qualities gained are considered to be cost-effective. And in general, when you get above $100,000 per quality gained, then that would be considered not cost-effective. And so how does the DPP sort of fit into that? So if you implement the diabetes prevention program in a group setting rather than in an individual format, which was the way the study was done, but in reality, we know in clinical practice, the DPP intervention is implemented in a group setting. And from a societal perspective, the lifestyle intervention costs about $13,000 per case of diabetes delayed or prevented. So I'll just clarify, because sometimes there's a little bit of misunderstanding around that. That's not per participant, but that is per case of diabetes delayed or prevented. So not everybody who participates is going to develop diabetes, and not everybody who participates, does not develop diabetes. So that accounts for both those factors. And importantly, $27,000 per QALY gained over 3 years. And the 3 years comes from the 3 years of the study. So $27,000. So that number is cost effective. However, and the last sentence in the last bullet I think is probably the most important, the benefits of the lifestyle intervention continue to accrue over time. So people who were enrolled in the diabetes prevention program continue to decrease their risk of developing diabetes over time. And so when you look over 10 years, the lifestyle intervention, and this is in the DPP, so implemented individually, so more costly, was about $19,000 and $20,000 per QALY gained. But when you look at how we would implement this in practice, so you implement it in a group setting, the costs are about $1,500 per quality adjusted life year gain from a health system perspective. So those are just healthcare costs, and about $8,400 per QALY gain from a societal perspective. The difference there being the societal perspective is all costs, no matter who pays. So some health economists would recommend looking at just the healthcare perspective. Others would say we should look at all of society perspective, but in either of those cases, a very cost-effective intervention. Next slide. Prediabetes has adverse health impacts. So we know that prediabetes increases the risk of developing diabetes, but it does have other health impacts as well. So one recent meta-analysis estimated an increased risk of all-cause mortality, about 1.1, for individuals with prediabetes compared to those without, over about 10 years. And that's a small increased risk, but over a large number of people, that's a significant mortality burden. And that translates into an absolute risk of about 1 death per 1,000 person years for people with prediabetes. And another study showed that the duration of diabetes and prediabetes during adulthood are independently associated with atherosclerosis and left ventricular dysfunction. So again, other impacts besides diabetes. Next slide, please. And related to that, lifestyle interventions have health benefits beyond diabetes prevention. So in the DPP, for example, the lifestyle intervention improved cardiovascular disease risk factor status. So people who participate in the lifestyle intervention have lower blood pressure, lower triglycerides, higher HDL cholesterol compared with placebo and metformin. And both interventions in the DPP were associated with reduced weight, so less overweight and obesity. And other trials as well have confirmed that lifestyle interventions are associated with reductions or improvements in blood pressure, lipids, and reductions in weight. Last slide, please. And this will sum it up. We also know, and we've heard from the other subcommittee, prediabetes and diabetes disproportionately impact socioeconomically disadvantaged populations. The other subgroup mentioned rural populations, as well as racial ethnic groups. So the first bullet is showing that non-Hispanic, Black adults have the highest prevalence of diabetes in the United States at 16.4%, and similarly, non-Hispanic Asian adults and Hispanic adults have a higher prevalence of diabetes compared to white adults. So there's a racial ethnic disparity in diabetes, and you've heard a lot about socioeconomic status, rural versus urban. And so ensuring that the DPP, or lifestyle intervention, is available to all people with prediabetes, and it needs to be tailored to the specific population and implemented equitably in populations with a higher burden of prediabetes and diabetes. That's going to be one step that's going to help us address some of the disparity in diabetes burden. That will finish this part. Are there questions? Right. Thank you. Yes.
Thank you for that excellent review, Howard. I think that one of the big take-home points is everybody who has prediabetes should be offered a diabetes prevention program.
Yes, definitely.
Yeah. So I think this is Dean. Can I ask a question, Howard?
Sure.
Yeah. So this is great. I think the clarification just made would make the recommendation even clearer. But I do want to raise an issue that I had raised last time, and you can tell me to go away at some point when I keep raising this. But I personally am a big fan of the DPP and lifestyle intervention. And I agree that the intervention has been shown to be cost effective. My concern is that we have a population, let's say 30 to 35% of the U.S. that would fit into this category of having prediabetes. And we have an incidence rate that is relatively low, depending on which study you look at. The ERIC study recently came out with even a lower incidence rate than what was presented, and a lot of people regress to euglycemia as well. And so while it's been cost effective at an individual level, the costs associated with scaling it up for every patient with prediabetes would obviously be remarkably prohibitive. And so I'm wondering to what extent we could be doing some precision public health work so that among the 35% of people with prediabetes, could we use either social science or metabolomics or genomics or some biomarkers to determine which subset of the 100 million Americans with prediabetes would most benefit from a DPP lifestyle intervention. In other words, which people are going to have the 20 or 30 or 40% incidence and would stand to benefit the most, because we're preventing diabetes, which in and of itself is not a death sentence. Obviously, you have 10 or 20 or 30 years to accrue before things bad start happening. And so we're talking about older people who may be dying of competing demands, and we're talking about a whole bunch of individuals who may have an exceedingly low risk of progressing to diabetes versus another subgroup who have a very high risk of progressing. So I'm wondering if there are ways that, whether it's through additional research that we do or recommend, that would allow us to do more precision public health and not what I imagine would break the bank pretty quickly.
Yeah.
Thanks.
Hi. So thanks, Dean. Now, that was I think there were like 3 or 4 questions embedded in there. So I can give you a short answer and a long answer. So the first is we agree with further research on sort of understanding the heterogeneity of prediabetes. So certainly if we can identify a subpopulation that has 0 risk or close to 0 risk, then we might not prioritize those people for a diabetes prevention program. Although remember that the diabetes prevention program does have additional health benefits besides preventing diabetes. So that's why I wanted to make that point. I am aware of the ARIC study, and I guess sort of two takeaways. That was an older population. So certainly as clinicians implement this, they need to use their, I guess, clinical judgment if a patient has competing priorities, for sure, or a patient has, other comorbidities that might limit their ability to benefit from diabetes prevention, then certainly it would make clinical sense not to refer that patient. If we think about scaling the diabetes prevention program up, yeah, there are a lot, like 80 million, as you said, people with diabetes, so pre-diabetes rather, so it isn't something that we're going to be able to implement in a year, but again, we're making forward-looking recommendations, and this might take 5 years to scale up or longer, and perhaps in the interim, it might make sense if you need to triage, which we don't like to do. If you need to triage patients, certainly go with the higher risk patients first. Those might be patients with higher levels of glycemia. And then in terms of costs, I actually don't think, because remember that it's very, very cost effective, and that you're going to decrease costs by having those patients who have prediabetes not develop diabetes. So one of the slides that one of the pieces of information that I didn't put in here was that if you look at, for example, intensive control of diabetes in patients with diabetes, that cost is about $44,000 per QALY gained. So you can make a very good argument that it really is more cost effective to prevent diabetes in the first place than to have somebody progress to diabetes and need this type of lifestyle intervention as well as medication, self-monitoring,
has it been shown to be has DPP shown to be cost savings? I know it's been shown to be cost effective. I mean, Bill Herman's work was very convincing in that regard, but has it been shown to actually be cost saving?
No, but it's very cost effective. But again, I think that then you put on top of that the person who's not developing diabetes. So certainly it's something that will take time to implement, and I think the short answer is yes. We have a recommendation about understanding heterogeneity in diabetes, and certainly refining this if we can find that really low risk population who might not be prioritized. So we would agree with that.
That's a great way to frame it, I think, to identify the heterogeneity and identify the population for whom this would not be as critical as for others.
Right. Yep. Agreed. Okay, John, I'll turn it back to you. I think we're about ready for Focus Area 1.
Thank you. And we, under Focus Area 4, we do have a recommendation regarding research into heterogeneity. And Dean, if there's alternate wording that you would suggest, by all means, please do. So moving into Focus Area 1, I'm going to ask David Strogat to take over. David, are you there?
I am. And so we have 4 recommendations under this focus area, and none of them are new. 2 have been revised, and we've highlighted the recommendations of the wording where there's been change. Beginning with the first recommendation regarding raising public awareness about prediabetes and the national DPP. The background bullets mentioned the history of collaboration between the CDC and the Ad Council on a national public service campaign to raise awareness about prediabetes. That campaign had included both a brief self-administered test for risk of prediabetes in locations where the national DPP program would be offered, and that's been tracked so that we know the number of people who visited and also the number who visited to find the location for national DPP website, but there's still certainly room for improvement in terms of both awareness for those with prediabetes and familiarity with the national DPP. The previous version of our recommendation was specific to existing or recent CDC cooperative agreements, and conferring with Ann Albright and Pat Schumacher, we adopted alternative language that's a little less specific and more flexible for how the CDC might want to implement this recommendation. It also includes added focus on populations most affected by type 2 diabetes risk. And I just want to read this because I saw in the Q&A from, I think, the public asking to restate the draft recommendations. So just quickly, to increase support to CDC to improve awareness of prediabetes and promote enrollment in the National DPP Lifestyle Change Program, especially among populations disproportionately impacted by type 2 diabetes risk, specifically to support CDC efforts to identify and engage popular social media influencers with numerous followers in key target audience populations, to develop and post custom content on their channels focusing on prediabetes awareness and the urgency to prevent or delay type 2 diabetes, and finally to continue tracking visits to the Do I Have Prediabetes campaign page and completions of the prediabetes risk test. Next slide, please. So this recommendation is unchanged. That is for CMS to provide coverage for hemoglobin A1C testing when used to screen for prediabetes. There's already coverage for fasting blood glucose and oral glucose tolerance tests, and this would simply be to add hemoglobin A1C as one option for screening for prediabetes. Next slide, please. This recommendation is also unchanged. The endorsement and promotion of the 2019 AMA proposed prediabetes quality measure related to screening for abnormal blood glucose by all federal agencies that directly deliver or influence delivery of care. And next slide, please. So here, the use of existing administrative data to identify patients meeting criteria for prediabetes. And the minor change in wording here is because the spirit of this recommendation is to perhaps explore and indicate potential efficiency of using existing clinical and administrative data to identify individuals who are likely to meet or may have already met criteria for prediabetes. And so we simply added the at increased risk or already meeting criteria for prediabetes in both background, the issues, and finally the recommendation that federal agencies that deliver care, for example, VA, DOD, IHS, should implement a process for systematically using administrative data to identify patients at increased risk or already meeting criteria for prediabetes and to confirm appropriate follow-up. And so those are our 4 recommendations in this focus area, and I would just sort of concur with what Howard and John already said in response to Dean's comment about, and you'll see in the 4th focus area for research, identifying or better understanding the heterogeneity of individuals with prediabetes, with the potential of then being more tailored in terms of assigning priority for who might benefit most from that program. And so those are my summaries of our recommendations for Focus Area 1, and unless there are some questions, can move on to Shannon and Focus Area 2.
Any questions or comments on Focus Area 1?
Can I just ask a question about the third bullet for number 1, where it says continue tracking visits to the Do I Have Prediabetes campaign page and completion of the prediabetes risk test? And maybe I just missed this, but is that just to show that people are, to see if that is, if the campaign is working? Is that the purpose of that?
Yeah, I think that's the, it's at least part of, and maybe a major part of, the evaluation of the campaign. If Pat has anything more to add from CDC about that?
No, that's correct, although we are looking at ways to build onto that page in the future to look at other things, one of them being where people go from there.
Okay.
Yeah, this is Dean. I just had one thought about the campaign, which is to consider partnering with ethnic media. I just don't know that the campaign is reaching non-English speaking and underserved populations as well as it could. Thanks. There is a national ethnic media entity called New America Media that is a kind of a clearinghouse for all ethnic media in the U.S.
Dean, are you suggesting we include some language in the recommendation regarding that?
Yeah, if possible, it would be nice to just to ensure the inclusivity.
Thank you.
Okay, I've made a note of that. Thanks.
Okay, moving on to Focus Area 2. Shannon, are you available?
Yes. Can you hear me?
Yes.
Great. Thank you. Okay, so we are Focus Area 2, which is focused on improving access to and utilization of effective type 2 diabetes prevention interventions. Myself, my colleagues Barry Marks, Pat Schumacher, and Naomi Suzawa have worked on this area over the past many months. So our first recommendation has changed slightly, but is still focused around the same issue and background. And the recommendation is to provide funding to collect, analyze, and organize the available data on the effectiveness and safety of using metformin in patients with prediabetes, with the purpose of submitting a request to FDA to review and consider an indication for the use of metformin in patients with prediabetes. The idea behind this recommendation is that metformin has been approved for use in patients with type 2 diabetes since 1995, and there is a body of evidence to support its use in delaying the onset of diabetes, but metformin does not have an FDA approval. FDA approval has many implications in terms of coverage and payment for metformin, and prescribing metformin for prediabetes is considered off-label use at this point. And use of metformin in patients with prediabetes is very low. Some research suggests less than 1%. And this may be related to the absence of an FDA approval. And the challenge with FDA approval with metformin is that there are multiple generic formulations of metformin, and there's really little financial incentive for a pharmaceutical company to pursue an indication. And while data could be submitted to the FDA in the path of a citizen's petition or by other means without the participation of a pharmaceutical company, there may be some prohibitive costs, or organizations may be unwilling to take on the responsibility associated with that. So our recommendation is that from our group, our draft recommendation is that we provide funding to collect, analyze, and organize the available data on the effectiveness and safety of using metformin in patients with prediabetes. with the purpose of then submitting that request to the FDA to review and consider an indication for the use of metformin in patients with prediabetes. I want to move on to our next recommendation if there are no questions regarding that one. Okay, our second recommendation is unchanged, and we recognize that this recommendation may be similar to other group recommendations regarding a coordinating body, but the recommendation is that we identify or establish a federal interagency coordinating body within HHS to review, support, promote, and implement proven evidence-based programs shown to be effective in preventing or delaying type 2 diabetes. And the background regarding this recommendation is surrounding the DMICC. The Diabetes Mellitus Interagency Coordinating Committee is chaired by NIDDK and includes members from from the Department of Health and Human Services and other federal agencies that support diabetes-related activities. And this coordinating committee facilitates cooperation and communication.
Shannon, we don't hear you. It looks like your phone line is dropped.
John or Howard, can you pick up while we try to get Shannon back on?
Howard, are you able to move on to focus area 3, then we could go back?
Yeah, let's do that. Let's go to focus area 3, and then we can come back to Shannon. Okay, thank you. The focus area 3 is about the sustainability of type 2 diabetes prevention, both at the individual and programmatic level. And I want to thank Barbara Linder, Barry Marks, as well as Pat Schumacher for contributing to our focus area. Next slide. Let's skip this one. We've seen this before. I just want to very quickly, next slide, please.
Hi, guys. It's Shannon. Give it just hold.
What should we do? Should I quickly go through?
Go ahead and go through focus area 3 since you've started, and then we'll go back to Shannon.
I will try to do this really quickly. This is a recommendation that hasn't changed. It just provides context for the next recommendation that's changed a little bit. So the problem here is that we have the diabetes prevention program, which is a one-year intervention. I was going to say 3-year study, but we don't really know. We don't have a lot of evidence or a lot of studies around the best way to sustain diabetes prevention for longer than just a few years. So this recommendation is that we need more research on the number, frequency, and contents of what we might term booster doses. That is, let's say, follow-up lifestyle interventions. Maybe it's a text message every month. Maybe it's something virtual that somebody who's completed a DPP can then go back and look at as they need every month. Or maybe it's a phone call every 3 months. But anyway, we don't know how best to sustain weight loss in type 2 diabetes prevention in the longer term. As we do these studies, we think that we need studies that look at the effectiveness of metformin and combined approaches, so metformin plus lifestyle intervention to prevent diabetes in the longer term. And also, as we recommend research on these studies, we'd like the studies to capture other health outcomes as well, because it would be very helpful to know that in the longer term, we're also preventing other health outcomes like cardiovascular disease, microvascular disease, and potentially mortality. And there aren't really a lot of studies that have looked at that. And so this recommendation, the next recommendation is slightly reworded from last time. So again, this is a research need, and this particular recommendation is around insurance coverage, but it's sort of forward-looking. So it's not for the DPP we have now, but what we find out in the future. So the issue is that if insurance coverage for a particular benefit or particular intervention is lacking or reimbursement is insufficient, then that really will hinder our ability to implement that. So it'll hinder our ability to implement whatever we find is useful in longer-term diabetes prevention. So our recommendation is ensuring that timely coverage and adequate reimbursement are included in the public payment system. This is primarily focused on CMS for evidence-based strategies that sustain long-term type 2 diabetes prevention. Again, we want to be proactive, making sure when we know it works, we can implement it in a timely fashion. Next slide, please. Really quickly, you've heard a lot of this. There are about 88 million people in the U.S. with prediabetes and about 34 million with diabetes, so a very prevalent condition. And definitely we know there's a disparate impact by socioeconomic status, by racial and ethnic group. Very costly illness, so estimated costs over $300 billion a year. We have evidence-based interventions that work, and we just need to sustain that at a programmatic level. We can't lag in our efforts to prevent diabetes. And just as one example, I've pointed out the Indian Health Service, which was able to lower the prevalence of diabetes in an American Indian Alaska Native population, which is at high risk. And they did that by maintaining a focus on diabetes prevention over several years. So next slide, please. So I've told you the background already. Diabetes is prevalent. It has morbidity. It has costs. It disparately affects certain groups. And we know that we have an effective way to prevent diabetes. The issue is that federal agency funding priorities can shift over time, and federal grants to improve community health may not specifically focus on diabetes prevention. So our recommendation primarily to agencies that do diabetes translational work and fund either healthcare within their own entities or things like federally qualified health centers. Federal agencies focused on disease prevention and health promotion should continue or increase their current level of commitment to prediabetes detection and evidence-based type 2 diabetes prevention programs. So we definitely want diabetes prevention to be part of the conversation, I would say, as federal agencies think about health promotion. I'm going to stop there. There are some specifics that we would need to follow up with some of the agencies about. There's some promising general, I think, health promotion and disease prevention activities or programs that probably could benefit from additional funding. But I don't want to get into the details here, and those still need to be fleshed out. So I'll stop there.
Howard, this is for
Howard
Dean
on
again.
Area 3.
Oh, yeah, this is
Sorry,
Dean again. Howard, can you move back to the slide that discussed the insurance issues, the CMS payment question around? Well, yeah, and I was getting confused. I just wonder if the recommendation is confusing. Before you were talking about sustaining diabetes prevention at the individual level through booster doses and other kinds of ongoing interventions. And then if you go back to the recommendation before that.
Which one? The one about we need research on what works?
This one. Thank you. Yeah. What was unclear to me is were you suggesting the recommendations that we sustain our support for DPP-like interventions in the community, or are you saying we should, as an public insurance, be supporting programs to sustain the diabetes prevention as in these booster programs? That was unclear to me.
Okay, so yeah, thank you. So we'll need to make that clear. This is more of a forward-looking recommendation, so it's not about sustaining what we have now. It is about being proactive when we understand what works. So it is.
So yeah, that's what I thought. And I just wonder if is it tenable for us if we don't have we may intuit, but if we don't know really what works to sustain prevention after the one-year DPP program, is it tenable for us to recommend that public insurance cover that thing in the future? I know the intent. I get it. I'm just wondering, is it actually defensible?
It's a good point. I think one way of dealing with that might be because we have recommendations around current insurance coverage, might be just to add not a specific recommendation, but additional text in there that talks about being proactive in the future. That's really what we're asking. We want to be proactive in the future so that when we know this works, we can implement it in a sort of timely fashion and with adequate. So we could roll that. Is that a better way of doing it?
Well, I don't know. I would kind of defer to Bill Herman in terms of like how insurance works in terms of, cost effectiveness, cost savings, and all that stuff. Like, what's the best way to kind of put the flag down and say, if and when we find a good sustainability model, can we get on insurance, public insurance on board now?
Yeah, that's exactly what we're saying.
And that's why we chose the words evidence-based strategies. So we're asking for coverage of evidence-based strategies once they're developed.
Right.
Yeah, okay. So, I'll see what Bill has to say when he comes back on. The other question I had is I really liked in the slide before how you were talking about the booster piece, and I wonder if that's also a place. At our last meeting, I had raised a question with Ann, and Ann may or may not have handed it off to you, Pat. But the question was that the current DPP curriculum, which was developed in the late 1990s, early 2000s, in terms of its dietary recommendations, and this is what's being scaled up nationally, it's very much a fat-based dietary recommendations. There are no mentions of added sugars or sugar-sweetened beverages at all at any point in the DPP approved curriculum. And Ann was going to look into whether or not the revision of the DPP curriculum was actually being undertaken, and if so, whether the dietary recommendations were going to be modernized, because it could very well be that the DPP could become even more effective than it is, the lifestyle arm that is, were the dietary recommendations to be include the added sugars and sugar-sweetened beverage component of what we believe to be driving diabetes.
Yeah, hi Dean, this is Pat. We are revising and updating the Prevent T2 curriculum. It's actually been underway for a few months now with an expert panel of nutrition experts from across the country advising that. So it should be released by the end of this year.
Great. And do you happen to know, or could you give us a sneak preview as to what will happen with the dietary curriculum portion?
Yeah, I haven't been privy to all the recommendations and all the changes that have been made, so I don't want to misspeak on that. But as soon as we have more information, I can definitely take that back and look into that.
Awesome. Thank you.
Thanks.
Okay, let's go back to Shannon now. Shannon, can you take over and direct us to the slide that...
Yes, thank you. Thank you. I was at the spot right here. Yes, thank you. We were talking about the DMICC and how, I'm not going to start over just in the essence of time, but I'll rephrase the recommendation at the end. The DMICC coordinates diabetes care among these federal agencies, but one of our issues is there seems to be a lack of understanding of how the statutory authority and the scope of the DMICC aligns with our recommendations, the NCC, for a federal interagency coordinating body. So our recommendation is that we identify or establish a federal interagency coordinating body within HHS to review, support, promote, and implement proven evidence-based programs shown to be effective in preventing or delaying diabetes. And as I mentioned, the similar recommendations likely occur in some of the other groups, the general population and the treatment and complications work group. Our next recommendation is regarding modes of delivery for evidence-based interventions. And the recommendation is to promote coverage for all proven modes of delivery for evidence-based interventions that produce successful patient outcomes consistent with the national DPP quality standards in delaying or preventing type 2 diabetes. And this recommendation is unchanged from our prior recommendation. And the background on this recommendation is that there is experience with delivery of evidence-based interventions to delay or prevent type 2 diabetes using a variety of modes across different federal agencies. And there's variation in coverage by private and public payers of different modes of delivery that have evidence of successful patient outcomes. And the national DPP quality standards are revised every 3 years based on a review of the literature. The issue that we're trying to work on here is that there are barriers to access, and I think Ellen Carroll spoke highly to this in regards to treatment and complications, which holds true in prevention of diabetes. There are barriers to access to evidence-based type 2 delay interventions, and offering these interventions through a variety of delivery modes may increase access. However, the coverage for alternative delivery modes varies across payers. So our recommendation is to promote coverage for all proven modes of delivery for evidence-based interventions that produce successful patient outcomes consistent with the national DPP quality standards in delaying or preventing type 2 diabetes. And we focused heavily on that language. As you see in that, you'll note as I go through other recommendations, that remains, that they're consistent with the evidence-based interventions and the quality standards of the national DPP. Our next recommendation is related to streamlining the CDC recognition process and the CMS payment process for the national DPP and the MDPP while maintaining quality. Congress authorizes the CDC to establish a national diabetes prevention program in 2010, and it is a public-private partnership that works together to build a delivery system for this lifestyle change program. The NDPP provides a framework for type 2 diabetes prevention, as we've talked about over the last couple hours here, and the physician fee schedule establishes a framework for the expanded model, enabling the NDPP delivery organizations with CDC full or preliminary recognition to enroll as MDPP or for Medicare diabetes prevention program suppliers to be paid. The CDC revises its diabetes prevention recognition program standards and operating procedures every 3 years in response to changes to the scientific literature, data from organizations, and public comment. And there are additional requirements for programs to bill Medicare. One of the challenges is that some organizations in rural and underserved areas experience challenges achieving preliminary or full CDC recognition and applying to become MDPP suppliers. The reason our language is phrased here to continue the efforts to streamline the CDC recognition process and the CMS payment process for the national DPP and MDPP while maintaining quality is that we recognize the importance of all of these processes to maintain quality in the programs, and so that organizations are meeting the quality metrics, but that the CDC and CMS continue to work to streamline that. The reason we use the word continue is that they do currently engage in efforts together to try to streamline these processes, but we recognize that it is still burdensome for many of the applicants. Our next two recommendations recommendations are approve MDPP as a permanent covered benefit, not only a model expansion service, and to lift the once-in-a-lifetime limit on participation in the MDPP and expand coverage to include virtual delivery. The issue regarding this recommendation is that the future of the MDPP as a covered service will be determined by the outcome of the CMMI expanded model evaluation. Full virtual delivery of the MDPP is not currently included under the expanded model, and this may limit CMS's ability to enroll a significant number of Medicare beneficiaries required to evaluate the expanded model. Virtual delivery of makeup sessions is part of the MDPP. However, under the national DPP, virtual delivery is permitted, and virtual delivery organizations must meet the same CDC national quality standards and achieve the same outcomes as the in-person delivery organizations, I should say. During the pandemic, the CMS issued flexibility regarding virtual delivery, and there may be variables that impact participants' ability to fully engage in or complete the program that may warrant additional intervention. And there may be a dose-related impact. And I think this kind of speaks to some of the prior group's recommendations in terms of dose-related impact, et cetera. So our goal, our recommendation here is to, again, approve the MDPP as a permanent covered benefit, not only a model expansion, and to lift the once-in-a-lifetime limit on participation in the MDPP and expand coverage to include virtual delivery. Any questions about this recommendation? Okay, hearing none, I'll move on. I think there's two additional recommendations here. This recommendation is to provide funding to support the testing of new models that allow for greater upfront payments and more equitable risk sharing between payers and MDPP program delivery organizations. The issue surrounding payment for MDPP is that the current payment model offers reimbursement only when participants reach certain attendance and weight loss benchmarks. And under this model, program organizations assume a level of risk that and may be under-resourced to cover the upfront costs associated with the program marketing and engagement and enrollment. More recently, large, primarily virtual program delivery organizations have been able to negotiate different payment schedules and rates with other insurers and employers that address some of the barriers in the current MDPP reimbursement model. And the MDPP reimbursement rates may not fully incentivize centers and programs to apply. Current MDPP rates may not be sufficient to cover the expenses of the program, and currently only a limited number of eligible organizations with CDC preliminary or full recognition have applied to become MDPP suppliers. And these, as we've seen in many of these other scenarios, reimbursement rates may have a disproportionate impact on smaller and more rural programs. So our recommendation is that this be revisited and that we provide funding to support the testing of new models that allow for greater upfront payments and more equitable risk sharing between payers and MDP program delivery organizations. I'm going to move on. I think that takes us to the end of our recommendations. And on to focus area number 4. John?
Can you advance the slides to 4? John, are you ready to go? We really need to finish up in about 5 minutes, so if you can make this a quick presentation. It looks like we've lost John. Can either Barbara or Ellen do this, or do we want to quickly, or do we want to break now and come back in 5 minutes?
Let's break and see if we can get John back.
Okay, so it's 3:16. I'd like to actually come back in 5 minutes if you can, so 3:20, 3:21. And please keep connected.
Hello, this is John Boltrick.
Hey, John, we just went to a break. We're going to return at 3:20, 3:21, and then have you continue with focus area 4.
Okay, I was I couldn't figure out why the slides weren't advancing.
Just a reminder to all of the Clinical Care Commission members that have joined, please be sure that not to move the slides as everyone can see them. We are on break and we'll return at 3:23:21. Bill and Jim, are you ready to resume?
Yes, Jennifer, I'm ready.
Yes, and I'm here.
All right, Jim, do you want to go ahead and do the roll call, and then we'll have John Boltree present for focus area 4?
Yep, I'm ready to go. Okay, this
And
is Jim
John,
Berger. Go ahead.
Sorry, go ahead, Jim.
No, I'm just going to start the roll call whenever you're ready.
I apologize. Go ahead.
Okay, this is Jim Berger, DFO. For record-keeping purposes, I'm going to start the roll call for this afternoon session after the break. If you're present, please indicate present so I can annotate accordingly. I'll start out. Bill Herman.
Present.
Pat Schumacher.
Present.
Howard Tracer.
Present.
Barry Marks.
Present.
Naomi Fukagawa.
Present.
Donald Schell.
Present.
William Chung.
Present.
Aaron Lapata.
Present.
Ann Bullock.
Present.
Barbara Linder.
Present.
Captain Samuel Wu. Repeat, Captain Samuel Wu. Moving on. Paul Conlon.
Present.
Ayata Tandi Dokan.
Present.
Carol Greenlee.
Present.
David Strogat.
Present.
Dean Schillinger.
Present.
Ellen Leak.
Present.
Jasmine Gonzalvo.
Present.
John Boltree.
Present.
Meredith Hawkins.
Present.
Shannon Idzik.
Present.
Jerry Bolin.
Present.
William Cook.
Present.
Great. Is there anybody that joined after that I might have missed when I went through your names? If not, we do have a quorum. I'm turning it back over to you, Bill, to lead the meeting.
Good. Thank you, Jim. And John, why don't you take 10 minutes for focus area 4, if you would.
Okay, thank you. So what I think I'll do is just focus on the changes since last time. So if we could have the next slide. There's no changes on the background for this slide, so next slide, please. So the changes, we added number 4 on the problem here, which is people with prediabetes are a heterogeneous group. Individuals have different underlying physiologic abnormalities that contribute to dyschemia. So some people with prediabetes may develop diabetes and other complications such as kidney failure more quickly than other people. More research is needed to better identify those people with prediabetes who are at high risk for developing diabetes and complications so that screening and interventions can be tailored to max. Next slide, please. So the recommendation then that's changed here is number 2. The NCCC recommends funding to support research to better define the heterogeneity of prediabetes and type 2 diabetes and to better understand intervention response and develop tailored intervention. Let me take a pause there and see if Dean and others feel like this is covering the issue.
I'm not seeing the slide. Okay, thank you.
So we have to really ask that you guys not move the slides, please. If they're not moving on your side, just please use the PDF.
So Dean, does that address your concern about the heterogeneity of treatment effect and tailored treatments?
Yeah, I mean, I think I liked what Howard had said as well, you know, to identify if there are groups that have very low risk of progression. But I think we can put that in the text. I think this is great.
Okay, let's move on to the next one. So all we've done here is we've sort of given a little definition of the 2 big research projects that are funded by the Special Diabetes Program for type 1 diabetes. That's TrialNet and TEDdy. So if we could go on to the next slide, please. And so We've changed the wording a little bit on the problem. The recommendation does not change, just a little bit different on the wording, though. DKA, a life-threatening but avoidable complication of diabetes, serious condition that can lead to diabetes. And in the United States, hospital admissions for DKA are on the. We talked about whether or not to put specific numbers in here because the numbers are fairly high, but there's not good agreement in studies on what these numbers are, so we just chose to use the word on the rise. And then we changed the wording a little bit for number 3. Previously, originally the program was funded for 5 years, and more recently had been funded only annually, but a recent appropriation provided 3 years of funding. So we just changed the wording a little bit to say special diabetes program, an important source of funding for developing new approaches to preventing and treating type 1 diabetes, was originally funded for 5 years, but the program has frequently been funded on only an annual. The recommendation didn't change, which was to fund the special diabetes program in 5 years. So I have one more slide that has to do with a literature search, but that's all I have for focus area 4. So are there any other suggestions or questions about focus area? All right, let's go on to the last slide for our group then. So I want to bring your attention to number 6. These are the 6 the 6 questions that we sent to the NIH librarian. And question 6 was really prompted by Ann Albright, which was to look at the effectiveness and risks of surgical methods for type 2 diabetes prevention. And what we found with our literature search was very few articles that specifically looked at type 2 diabetes prevention. There were 1 or 2, maybe 3 that included some people with obesity or prediabetes, but they didn't specifically randomize folks with prediabetes against in a randomized controlled trial. There were, I think, somewhere in the 60 to 70 number of studies, but again, most of them dealt with people with diabetes. So I think the question I am posing to the whole commission is, we know that bariatric surgery is an excellent way to delay or prevent type 2 diabetes complications. Many people go into remission and stay in remission for life after bariatric surgery. So the question to the commission is, should we have a mention of bariatric surgery in our final report?
John, just to clarify, do you mean bariatric surgery for type 2 diabetes prevention or bariatric surgery for diabetes treatment and complications?
Really, thank you, Bill. The question is for either or both of those. I didn't get the idea that any of our 3 groups are considering including that at this point, so I'm asking the whole commission if we should include a mention about bariatric surgery for type 2 diabetes prevention or type 2 diabetes treatment. From a type 2 diabetes prevention, we could recommend research on bariatric surgery. For treatment, we could recommend including that in one way or another. Or we could just have a separate section that talks about the effectiveness of bariatric surgery for type 2 diabetes.
So going back, this is Bill Herman again, going back to Dean Schillinger's point, I just don't believe that bariatric surgery for diabetes prevention is going to be affordable or it may be cost effective, but certainly not affordable as a population approach to diabetes prevention. So my feeling is that it's really not appropriate to consider for diabetes prevention, besides the fact that there's just not good evidence for it. One would presume that it would work, but there's certainly, as you pointed out, no good trials suggesting that it does.
And what about including any information in our report about bariatric surgery for treatment of type 2 diabetes?
Well, there I would defer to Paul and Carol's subcommittee.
Yeah, John.
Is it true that there have been no longitudinal studies of people with diabetes who've undergone bariatric surgery? Maybe no trials, but are there longitudinal studies?
Of pre-diabetes?
No, of diabetes. Diabetes.
Oh, yeah, there are lots of studies in diabetes, but and good randomized controlled clinical trials, but very little in pre-diabetes.
Right, exactly. I maybe I misunderstood the summary of the search.
Sorry, the summary again was that there have been no randomized trials for diabetes prevention. Of all the studies that have been done, they've mostly done on treating people with diabetes, and in very small number they've included a few people with prediabetes.
John, I wonder if this goes back a little bit, this is Shannon Isaac, a little bit to the heterogeneity comment, because I agree with Bill, while it might not be a prediabetes population intervention that's affordable, there may be groups of people for which it makes sense. If it's a young, I'm just going to throw out the younger portion of people with other significant risk factors, including first degree relatives, gestational diabetes, et cetera. There might be a population that it serves us well to consider, much like the heterogeneity in diabetes prevention programs.
People who would disproportionately benefit as well. Is that what you're saying?
Yes, people who would disproportionately benefit, or those who it won't likely benefit.
This is Meredith Hawkins. I would think that because it is now becoming so widespread, it should be in there somewhere. It should be mentioned. One aspect, so two aspects, I guess, of all of it. One would be what's just been mentioned, the lack of data, particularly for prediabetes. But I would say number two, the fact that the research in the field is attempting to develop simpler models that would manage to retain the metabolic benefits and yet be less invasive. And so for that reason, at least having mention of this, we would have to hope in the future that there might be less expensive, more feasible, less invasive means that might still have metabolic benefit. And for that reason, I'd like to make sure that there is a mention, ideally, of the topic.
So we've referred this to the treatment and complications group, but I'm not sure if that was the right way to go. So I'll kind of leave that as a hanging question at this point.
John, this is Paul Conlon. Carol and I did receive your literature search on bariatric surgery as a treatment for diabetes. We'll bring that to our subcommittee. One caveat is that as a group, we have tried to shy away from investigating specific interventions as it may relate to treatment of diabetes, only because that is a huge topic in and of itself. And while bariatric surgery may have promise, there are also lots of other pharmacologic interventions that we've tried to not necessarily dive into. So as a result, it might be a high bar for us to specifically investigate that topic.
Understood, and I appreciate that. That's why I wanted to bring it to the table for the whole commission to weigh in of whether we should include a mention. It wouldn't be hard to make a separate paragraph summary if that's what we decide to do.
And it might belong, based on Shannon and Meredith's comments, it might belong in the research needs topic area and expand it beyond bariatric surgery to other approaches, surgical or procedural approaches to diabetes prevention.
Okay, thank you. I think we're ready to move on.
Thank you. This is Dean. Ann Bullock is on the line, but is under the weather today, so I'll facilitate and we'll do so with my colleagues Carol and Aaron to some extent. First, I wanted to thank the other two subcommittees. Amazing work, very complicated topics. It's very, very inspiring to see the progress you guys have made, and hopefully we can inspire you as well. Next slide. You're familiar with the members of our group. I'll point out that Carol is now received the Master of the American College of Physicians title, so congratulations to you, Carol. So today I'm just going to update the Commission on the progress we have made with respect to the literature search and additional key informant presentations in the time period between our last National Clinical Care Commission meeting, present some revisions and expansions to prior draft recommendations for your review and comment and feedback, present new draft recommendations regarding filling some research gaps, and describe the next steps. Next slide. Before we start, I just wanted to remind the group as to why this subcommittee exists. This question has come up a number of times with respect to the charge of the Commission, the concern being whether our recommendations fall within the scope of the charge or fall outside of the scope. And so we actually met with the Office of the General Counsel and reviewed this. I wanted to share this with the Commission as a whole because it will be us as a whole, we as a whole, who will decide what to put in and what not to put in our final report. So in reviewing the charter with the Office of General Counsel, these were the relevant quotations from the charge, that the Secretary of Health and Human Services is required to establish a committee to evaluate and make recommendations regarding improvements to the coordination and leveraging of programs within the department and other federal agencies related to awareness and clinical care for diabetes. The key point here is the other federal agencies, because a lot of the recommendations we have drafted relate to non-HHS agencies, not exclusively, but in large part. Elsewhere in the document, there is mention that the charge includes the improvement in and improved coordination of federal education and awareness activities related to the prevention and treatment of the diseases and its complications, current activities and gaps in federal efforts to support clinicians in providing integrated high-quality care to individuals with the diseases and complications, and the established subcommittees may consider issues in accordance with the mission of the Commission and shall, as appropriate, make recommendations and a report to the Commission for consideration. This question came up most acutely with respect to the recommendations we have made around health impact assessments across federal agencies and the concern that it was outside the scope. And we were provided reassurances that actually it falls within the scope, whether or not it could be applied to all federal agencies or whether we should be more specific with respect to which agencies have relevance to diabetes was a question put back to us. But the OGC offered to review all of our recommendations once we have final drafts to ensure that they are aligned with the charge. Next slide. To answer the question as to whether non-health agencies' work that we have addressed are aligned with the NCC charge, we have come up with 6 rationales. One was to improve diabetes prevention and care in the U.S. and to reduce diabetes-related disparities. It is now widely recognized that supportive changes to the social and environmental conditions are essential to improve both individual and population level outcomes. Clinicians now routinely are encouraged to refer for social services such as food and housing, but resources are known to be inadequate for clinicians and their patients. It's been shown that clinicians who care for people with diabetes have been found to have high rates of burnout, in part as a result of feeling unable to address their patients' social needs. Further, both private and public health plans have been making investments in addressing such non-health factors, and CMS has become involved in some of these activities. Further, non-health agencies, with respect to awareness, must become more aware of how their policies and practices either advance or undermine efforts to prevent and control diabetes. And in some instances, the work of relevant non-health agencies should be leveraged and coordinated, to use the language of the charge, to prevent and control diabetes. So I just wanted to give that preface before we dive into some of the revised recommendations that we will be presenting today. Next slide. So a reminder of the relevant federal agencies that we have been considering in our work. The red asterisks represent recommendations, represent agencies and departments for which recommendations have been drafted already. The black asterisks represent agencies and departments for which recommendations will be developed between now and our next National Commission meeting. Next slide. In the time since November 2020 till now, we have had 6 additional key informant presentations. One from a former CDC branch director who worked on junk food marketing with the FTC, Dr. Bill Dietz. We met with the Bipartisan Policy Council. Thanks to Carol Greenlee for that hookup around what nutrition policy efforts they believe are important and could get behind from a bipartisan standpoint. We met with David Vladek, a former FTC chair, about the prior FTC efforts regarding marketing to children. We met with an attorney at the FTC regarding current ability of FTC to regulate marketing to children. A lot of meetings with the FTC. It's a very complex set of issues that we will be sharing with you at our next national meeting. We met with, as I mentioned, Pam Perlin from the Office of the General Counsel about health impact assessments and the scope of this subcommittee. And then we met with Fida Baca from the USDA Agricultural Research Services. We also had content provided by 2 experts, Dr. Bree Williams on the Federal Bureau of Prisons policies around diabetes prevention and the environmental context in prisons, and Dr. Bimla Schwartz about what is known about the relationship between breastfeeding and maternal incidence of maternal diabetes, as well as the potential role for federal programs both within HHS and in other departments promote breastfeeding. And we will be presenting draft recommendations on those in the upcoming meeting. Next slide. We have completed a very extensive diet and nutrition lit search with a total of 3 domains with 3 subsets of questions within each domain, so 9 research questions for the search, leading to well over 1,500 articles for us to review, and we have completed these as individual leads for our particular recommendations that we will present to you. Next slide. So I'm going to now present 4 or 5 updated draft recommendations that align with our previous presentations to you as a group. And here I have put in, whatever this color is, teal, the revisions that we have made to the prior recommendations that we had presented previously and had received a general consensus approval from the group. So this overarching recommendation has to do with engaging in particular non-health agencies, in the leveraging and coordination of work to prevent and control diabetes. And it reads as follows. The NCC recommends the creation of an Office of National Diabetes Policy in the Domestic Policy Council of the Executive Branch. This is akin to the Office of the National AIDS Policy that sits in the White House as well. The purpose of this ONDP would be to develop and facilitate a national diabetes strategy that leverages and coordinates the work of relevant federal departments and agencies as outlined in the NCC report that we will be putting forward. The NCC recommends that a new federal program also be created within the Office of the Secretary of HHS to work with the Office of National Diabetes Policy and specifically with the CDC, which has a very important leadership role in its Division of Diabetes Translation, to foster broad trans-agency collaborative work aimed at positively changing the social and environmental contexts that are promoting the type 2 diabetes epidemic. In addition to the departments and agencies within DHHS, this entity should include, but not be limited to, the USDA, the Department of Transportation, Education, Justice, Defense, Labor, FTC, EPA, and the Bureau of Indian Affairs. The NCCC recommends that this entity would have as its primary responsibilities to facilitate coordination among federal agencies with respect to trans-agency approaches to preventing and controlling type 2 diabetes, make recommendations to the executive and legislative branches regarding actions they can take to prevent and control type 2 diabetes, pursue a health and all policies agenda with respect to diabetes, and promote the use of health impact assessments for relevant policies across non-health departments and agencies. So in summary, the main revision that we have created to our prior draft recommendation is the bolstering of a national effort on the part of the Secretary of HHS by creating an additional Office of National Diabetes Policy to promote and facilitate the work of non-HHS agencies in collaboration with the Secretary of HHS and the CDC. So I'll stop there for comment and questions.
This is Meredith. I think this is excellent. Very well thought through, and I think it would be a great recommendation.
Thank you, Meredith.
Hi, Dean. This is Bill Chong. I have a clarifying question. Just if you could just kind of help me understand a little bit more how the executive branch office and the HHS program, would they be linked, or are they separate, or is there overlap in sort of what you're envisioning?
Yeah, that's a great question, and I think we have been modeling this on the work that's been done over the last 15 years or so on AIDS, and I'm going to pass it on to Aaron Lapata, who worked for a time in the Office of National AIDS Policy and now, as you know, works at HRSA in HHS. So I think he could speak most directly to how HHS and the executive branch have worked together, in at least in that context.
Yeah, thanks, Dean. So I think the idea of having an office within DPC, or a group of domestic policy staff working on only diabetes as part of that office is to elevate it to a White House level that helps drive, not only helps drive the policymaking, but the office has more power or more influence to be able to pull in other departments outside HHS. So if you would have, so in regards to ONAP, which is the Office of National AIDS Policy in the White House, they work very, very closely with the I'm forgetting the acronym, the AIDS Office for HIV/AIDS at the Secretary level at HHS. They work very closely together, but I would say the White House DPC Office for National AIDS Policy, it helps to have them at the higher level to be able to pull in and help coordinate the work of not only agencies within HHS like CDC, HRSA, NIH, but also other agencies that do work around HIV, which is almost a lot of the departments all do some type of work there, particularly the Department of Defense. I'm trying to think of AD as well, because there's international
Prison, Federal Bureau of Prisons. Yeah,
absolutely. Federal Bureau of Prisons. Thank you. That's a much better example. So having that office at DPC, I think, will help drive the policy and help elevate it to the priority of the White House and give it more teeth. But they work very closely with the office at the HHS level as well. It's very much a team-based approach. So they would be separate offices, but they would work, closely together. But I think the White House or DPC office would help, take leadership. And of course, it depends on the administration, what their priorities are as well. But if you have an administration that really cares about, diabetes-related policy and then implementing effective prevention treatment policy, then they will make that office a priority and make sure that office drives policy across the federal government. Does that help?
Yes, Aaron. Thank you for that. I think that makes sense. Having somebody at the White House level can facilitate with division departments outside of just HHS. I think that makes a lot of sense. Thanks for that.
Of course.
So this is Barbara. I have a question. I think the concept makes sense, but I guess I'm a little unclear as to what you envision the role of the CDC is, in the sense of trying to really foster trans-agency collaboration. It seems like if you're really trying to do something in that sphere, then, it should be coming from HHS rather than, one of the agencies that, should all sort of be co-equal in coming to the table to develop these programs and policies. Does that make sense?
Yeah, I think I understand. Aaron, you wanted to take that? Yeah, so I think I understand your question, Barbara. I think our intent here is, if at all possible, to empower the CDC to the extent possible to enable the CDC to be able to do the kind of trans-agency work that they very much are well positioned to do and want to do, whether or not the fact that they are perhaps a smaller fish than USDA and the appropriate person would be a designee of the Secretary of HHS. I would imagine that decision, if the CDC were selected to serve in that role, that to me would, as a designee, that would elevate the CDC. But I would defer to Pat to see what her thoughts are on that particular question and on this recommendation as a whole, because I know we had a number of conversations with Anne about the risks and benefits of kind of elevating diabetes to the executive level. And let me just say before I hand it off to you, I think our job, as best I understand it, is to make recommendations, as in describe the what, but that we shouldn't feel we need or should or can get too much in the weeds as to the how, because that crosses a boundary with respect to what federal advisory commissions are allowed to do. So we're somewhere on the fence on this one. So that may explain part of the lack of clarity here.
So then can I make a comment before Pat?
Yeah.
Talk to. So I mean, I do see what you're saying, and I, again, the reason we bring these recommendations to discuss today is so we can work these things out. And I think there's an argument to be made that NCC, that the this new office and at the secretary's level at HHS, working with the White House office in DPC, they would obviously be like the point people. And we know CDC here, but I think effectively we don't necessarily have to call out CDC specifically. So I think the lead would be, especially within HHS, would be White House DPC working with the HHS secretary level's office, and then working across the HHS agencies, whether it's CDC obviously has a major role. HRSA has a role, of course, as well. I mean, all the agencies, FDA, and of course NIH as well. So we don't necessarily have to call it CDC here. We can talk about that further. I think the more important part of this recommendation is the idea of having an office at the DPC level and at the secretary's level that would take point on that. And I think that the level at DPC would, the office of DPC would help with the coordinating across the departments outside HHS. But when it comes to agencies within HHS, it'd be the DPC and the office at the secretary's level. Does that make sense? Dean, do you think that's right?
Yeah, I think that you're right to point out that I inserted CDC, and part of that is because that's where my heart is, and so I wanted to make sure that this recommendation would actually empower the CDC's Division of Diabetes Translation rather than supplant it. So now we can hand it off to Pat.
Yeah, thank you. This is something I think I would, before I comment, I would like to take back to our group in the division to get some additional feedback. I think it's an important recommendation. I'm also sensitive to the fact that we have, I know this is a bit different in terms of its scope and focus, but we have other recommendations, at least one I know in focus area 2, about an interagency coordinating committee. So I'm just also wondering if these efforts aimed at coordinating across the federal agencies, if there might be a way to consolidate some of that or combine some of that.
Yes, and Bill Herman actually pointed out when we were developing this revision that this recommendation actually relates to the entirety of the commission, the entirety of the subcommittees here. This is not unique to our subcommittee.
Yes, makes sense.
Yes. Dean, this is Naomi. I also, agree that it should be a trans federal committee, and would caution against placing too much emphasis on relying on the present administration and or political appointees, because that can change if obviously administrations change. This should be something that would be sustainable and sort of cover across administration.
I think that concern is relevant to the heads of agencies and departments as well, right? So Aaron, do you want to comment on what you've seen in terms of the Office of National AIDS Policy in that regard? I share your concern, Naomi.
No, but it's a really good point. I think we have some recent evidence to support Naomi's point as well. I would just say having an office, if you're able to establish an office or in DPC, because obviously it has to, you're starting something new and it's up to another administration to continue it. I'll say the Office of National AIDS Policy has continued and maintained as an office throughout. So I mean, I started working, at least in 2004, I worked with the office through Bush, Obama, and then it was staffed by Bush, an important office in George W. Bush's administration. Obama's office was very important. And then actually, I don't think the Trump administration really staffed it. But now I believe it's going to come back in the Biden administration. So you are right in the sense that it's not always, there can be administrations where it's not a priority or it's not staffed. However, having the office there means it can be restaffed. And I would say that the office during the Obama administration in particular was really critical because it was that office that the Office of National AIDS Policy that led, it was point and put together the National HIV/AIDS Strategy. And that required, that strategy, incorporated, all across, had responsibilities laid out across the federal government, across all departments, and in state and local governments as well. But it really played a critical role. So I think having an office there that could be staffed by the White House and prioritized, I think is important. But I also think, Naomi, what you're saying also kind of highlights the importance of also having the office at the level of the office of the secretary, or if it's a program or office that's dedicated to addressing, preventing, treating diabetes at the level of the office of secretary. And I think that office is probably maybe a little bit less political, or a little less vulnerable to political back and forth. It's a little bit more stable. I think having that office is also critical. So I don't think so I do think it's important to have, but you are right. You don't think it undermines? No, it absolutely does not undermine. No. But I do think that it's important to consolidate. We shouldn't have multiple committees, coordinating groups. We should have just as many as we need. And I also don't think having an office at DPC, having an office for that focuses on prevention of diabetes at the office of the secretary at HHS, neither one of those would supplant CDC or any of the agencies. CDC is going to be important because they get a lot of funding and they do important work, and that makes them absolutely critically valuable. So they're always in these meetings and they're always there. I don't see anything supplanting. It's just a matter of having point people higher up to help drive it and make it a priority. And that's what essentially is needed.
Yeah, and I think that just to highlight a point you made, Aaron, which is the importance of the National AIDS Strategy, that I think it's important for us to recognize that in the second line of this recommendation, one of the first tasks of this office would be to facilitate and create a national diabetes strategy, which to my knowledge, we do not have as a country.
Sure, right. No, absolutely. And yes, and I think having those offices, again, at the White House and at HHS would be critical. And I think you would need to have support and input from the administration to do that. I know it's a lot, so if anybody have any other questions or concerns?
This is Sherry.
Bill?
I like...
Oh, yeah, go ahead, Sherry.
I was just going to say, I like this recommendation, but I also was just confused with the ONDP and CDC, and so I would be in favor of leaving that as ONDP and having CDC participate as one of the, as all the agencies within HHS. I think having both the way it's written is confusing, and yes. I think that's just a general take.
Thank you. That's helpful. So, Bill, let me just ask Bill Herman. So, what is the status of this revision? Is there's general support, but we want to hear back from Pam, from Pat Schumacher. Is that a fair summary?
So that's what I heard, and I think, I think there seems to be consensus that this is worth pursuing.
Okay, so let me hand this off now to my colleague Carol.
Okay, thank you. So we presented some of these recommendations at the last full meeting. and we have added a couple, so I want to go over those, and I know we're probably starting to run short of time. But both food insecurity and insufficiency and poor diet quality contribute to the onset of diabetes and complications from diabetes. And food insecurity can do that through a variety of mechanisms, including poor diet quality, the metabolic upset of having food, not having food, stress pathways, and then competing demands, because when you don't have enough food, that becomes your primary focus, not checking or controlling your blood sugars. So we recommend that the USDA modernize the SNAP program to further reduce food insecurity and improve dietary quality to help prevent the development of diabetes and diabetes complications by implementing the following changes. And the first three items I will lump together as benefit allotment because we talked about the importance of having more fruits and vegetables in improving dietary quality, reducing cardiovascular disease and diabetes. We talked about reducing sugar-sweetened beverages in particular as the main source of added sugars. No other nutritional value, increasing energy consumption and directly linked with obesity and increased risk of diabetes and diabetes complications. And so those combined are much more effective and have been shown to be cost-effective to very cost-effective. But you have to be able to buy the foods that are healthy. And so this benefit allotment, I want to try to explain why we feel like this is important. SNAP is supplemental nutrition assistance program with the intent of supplementing the ability of an individual or household to purchase foods for consumption at home that will attain food security and a healthy diet. And so there's a certain amount of money that is considered to be enough to reach food sufficiency and a healthy diet. And for SNAP, that's based on something called the Thrifty Food Plan. And there's a variety of different market baskets within the Thrifty Food Plan based on the household makeup. Over the years, the cost of buying a Thrifty Food Plan has been adjusted upward as the cost of food has gone up, but what has never been adjusted are other circumstances that can impact one's ability to meet their nutritional needs and even their food sufficiency based on the amount of food, the amount of money provided by the funds for Thrifty Food Plan. And things that can affect that are geographic differences in food costs, so San Francisco versus a small town in Iowa, seasonal changes in food cost, and availability of the foods in this Thrifty Food Plan. And when they give this to academic medical centers or academic centers to test it, and they say they often have to go to 4 different stores to find the best price of these basic foods that go in the Thrifty Food Plan. But probably the biggest one is time. The amount of time it takes to find the foods in the Thrifty Food Plan and prepare them far exceeds the amount of time most people would ever devote to food shopping and food preparation. And we have stressed families that often have a one working parent who doesn't have the time to do that. Now, this is a supplemental program, so it's not meant to provide all the food. So whatever amount of money is determined by the Thrifty Food Plan and the appropriate market basket is reduced by the benefit reduction rate. So the amount of income, and income is determined by not only their job income, but other benefits that they get. It's estimated that the average person or participant in SNAP has 30% of their income available to spend on food. This has not been updated for many, many, many years. In 2013, when the Institute of Medicine looked at it, a wealthy or higher income family spent 11% or had 11% of money available to spend on food, but a low income family had 13%, so more of their money needed to go to food. And how that's calculated is very, very complicated. They take housing into account, but there's a cap on housing expense, and as you'll hear, that's its own problem. So more recently, it's been estimated that these low-income families at, below, or slightly above the poverty level only have 8% of their income available to spend on food. So that's a much smaller number that will then be subtracted from the funding for the Thrifty Food Plan. So people are getting much smaller supplemental benefit allotments, and then they can't meet their food sufficiency needs or their healthy diet needs. So I know that's complicated. I hope I didn't make you too dizzy, but on both ends, the Thrifty Food Plan has its own problems, even though the cost of food in that has been updated. Other things need to be updated, and that could be improved by moving into the low-cost food plan. And then the benefit reduction rate, the income criteria is in drastic need of being updated, and then people could better meet their food sufficiency and healthy diet needs and help prevent diabetes and help treat diabetes when they have it. So I will stop there. I hope I didn't get everybody too lost by trying to explain.
And just, no, thank you, Carol. That was wonderful. Just to summarize, the bullet points 1 and 3, I don't know why the color coding didn't come through on this PowerPoint, but 1 and 3 represent the revised recommendations, and bullet points 4, 5, and 6 are ones that we had presented previously that relate to the nature of the benefit, whereas Carol's conversation has to do with the allotment. Who gets in? How are the income criteria determined to determine the amount of the SNAP benefit, and then how that determination is made with respect to some gold standard of food and related costs. Questions, comments for Carol?
Is there support for this?
Yeah, I think it's great.
Yeah, it's Howard. I was going to say the same thing. Now, this is really good, and it puts a little more specificity into it. I think it's really nice.
Do we need to be more specific? Sorry. Do we need to be more specific? I mean, Carol gave a long explanation because of its complexity. Do you think that these bullet points capture the nuance of what she was trying to communicate?
I think they capture them very well. I think there is very good specificity here.
Yeah, I agree. I mean, I think you'll have to write out below bullets what that means, but I think the bullet point is clear.
Terrific. So let's move on to the next slide. Thank you, Carol. And I'm going to pass this on to Erin. So just to frame this, Carol was speaking about the individual level nutrition assistance programs given to families and individuals. And Erin is now going to talk about the programs to provide nutritional assistance to populations, particularly populations of children that are provided at an institutional, typically at an institutional level.
Thanks, Dean. So yeah, so what we're looking at here are the primary federal nutrition programs for children, and that consists mostly of the National School Lunch and Breakfast Program and breakfast programs, and the Summer Nutrition Program, the Fresh Fruit and Vegetable Program, and of course WIC. And our recommendations really are focused on making sure that we expand these programs, and what we mean by expand is make recommendations that help increase the number of kids who are eligible for this program, and also facilitate the or reduce the paperwork and the burden of enrolling for these programs. I mean, right now, the National School Lunch Program serves about 30 million children per day, but more can be done in terms of getting more kids enrolled who require these services. And I think part of it is, it should be noted that a lot of great work and great progress was made with the passing of the Healthy, Hunger-Free Kids Act in 2012. And since that time, the USDA has improved the nutritional standards for all these programs and all foods served in schools. But one of the challenges is that the schools sometimes run into problems of implementing this, either because they don't have the staff or they don't have the type of equipment in the kitchens that they require. You wouldn't think that it would make a big difference, but the type of having older equipment that isn't really intended to make from scratch food, if schools don't have that, it's very hard to meet the standards. And so some of this also involves the federal government providing additional funds to schools so they can implement these these new standards of higher food standards for healthy foods.
You want to go
really
to the next slide? Do you want to, Aaron? Do you want to
absolutely.
Go to, yeah.
Yep. Yeah. So here's this is our the recommendations I started going over before looking at the slide. So one of the first recommendation is to maintain the nutritional standards that have worked so far from the Healthy Foods Kids Act. I think that sort of the little bit of the drive for this is under the previous administration, they relaxed the standards a little bit. They backed away from the standards, and I think there's a lot of push from advocates and experts on these policies that we really want to make sure that these standards aren't allowed to slip, because they're all evidence-based. They're all made through recommendations from experts across the country and dietary groups across the country. So we really want to make sure that these standards, nutritional standards, don't slip. And again, and then let me just focus on the ones that are new. We have the prohibiting the sale of junk food on public school campuses, and developing an incentive program to enable schools to cover essential costs previously underwritten by the sale of such unhealthy foods and beverages. Because I think this is just another way to ensure that on school premises that these foods or beverages won't be sold. I think we had a little bit of concern that some of the beverages in foods may be sold at some of these schools because of the resources and funding they get from those companies. And so one of our ideas was to ensure that the federal government could be able to cover any costs or resources lost due to I don't want to use the word banning, but not permitting the sale foods that don't meet the nutritional standards.
And one other point to make, Aaron, is that while the CDC has, for a long time in its list of evidence-based recommendations for the prevention of diabetes, included the elimination of these foods and beverages from public schools in America, the degree to which public schools in the United States do this vary tremendously by state, and a significant majority of public schools do not prohibit the sale of junk food on their campuses. So most young people can easily acquire junk food on the school campus, and I believe dietary consumption at school or around school represents 60% of what young people eat in a day. And further, a study has shown that those states that have more vigorous regulations for their districts around junk food sales on campuses have been found to have lower rates of obesity than those states that have lax regulations.
Yes, that's right. So I think, no, that's absolutely right. The studies have shown that when kids have access to healthier foods, not only do they consume the healthier foods, but that the schools that have the higher standards have demonstrated lower rates of obesity among the children who attend those schools. And then, okay, so
can you go back? Yeah, Jennifer, can you go back?
Thanks. I wasn't sure if I was being pushed to go on, but I understand that drive. So the next two we'll kind of put into two categories. One is we amended the previous our previous recommendation, which is really increase funding for and improve access to participation in summer food nutrition programs for kids who who depend on getting their food from meals in school. In the summertime, they're not in school, so they're vulnerable. We wanted to add and we can provide more detail on this later, but we wanted to be able to make a point that we want to be able to fund these programs so that they are able to serve whatever the population needs are. So whatever number of kids out there meet the eligibility criteria for these that need these services during the summer, we want to make sure that they're able to be served. And it's been a little bit of a challenge so far finding to determine how much of an increase that would be, because a lot of it has to do with where you set the eligibility criteria. But there's definitely kids who are and families that are face food insecurity, and I think millions more could still be served, and we want to be able to make sure that we recommend that these programs are expanded so that those kids, every family and child that is facing food insecurity is served by these programs. And similarly with the expanding the reach of the fresh fruit and vegetable program for elementary school students. Again, I think the purpose of this program is to introduce fresh fruits and vegetables in the schools, but also educate kids about the importance of eating fresh fruits and vegetables. I think that this has been found to be effective in improving the diets of kids at schools, and we just want to make sure that we are able to expand it so every school that wants to utilize one of these programs and implement this program will have the resources to do it. Okay.
Any questions?
So, I don't know.
Any questions?
Yeah.
Let me just ask, any questions? If you go back one, Jennifer, any questions on the recommendations related to junk food sales and scaling up these programs? Or to channel Carol, is there general support for these?
I think general support.
Again, please stop moving the slides. It moves it for everyone. Please use the PDF.
Okay, Aaron, you want to continue?
Yeah, well, we go to the next slide. We don't have any changes here and these recommendations yet. Again, we want to make sure that all people are farmers who want to sell, create, make or plant and produce specialty crops has the ability to do so. It's not clear right now if the demand is outweighing if the demand is outweighing the amount of if there's more demand than the current level of funding is providing in terms of support for these specialty crops. I haven't been able to find evidence that that's the case, but we do want to make sure that these programs are serving farmers and any farmer that wants to be able to produce specialty crops has that support. Similarly, with the food financing initiative, we want to make sure that every underserved community has this program to be able to help support at the point of purchase and help encourage people to buy healthy foods in their local supermarkets. And so nothing specifically changed here, but we do want to make sure that these are financed fully based on the demand.
Can you go to the next slide? I think we have the recommendations there. It's basically exactly your point that currently the USDA, the Farm Bill, about 0.3% of the Farm Bill goes to this issue of specialty crops, which is a short term for fresh fruits and vegetables. And so we're recommending expansion and funding to achieve population-wide benefits.
It's a general recommendation, but does anybody have any thoughts on that or objections?
All right, let's go on.
Not very controversial. Yeah.
Bill, do you want to tackle this? Or you want me to do it?
Go ahead, Dean. That's fine.
Yeah. So this is just a reminder that we had presented and received agreement around a draft recommendation regarding prohibiting the sales of sugar-sweetened beverages in government-owned facilities. And for now, we've just revised the recommendation to delete healthy beverage alternatives that raised a lot of issues around diet sodas, etc. And then just acknowledgement that let's move it back, that we need to discuss amongst ourselves and then with the larger group what the implications of this would mean for the U.S. military. Would love to hear Donald's opinions on this, as well as what it would mean for the Federal Bureau of Prisons if prisoners would not have access to sugar-sweetened beverages. That's an important consideration that we had not worked through before. So would love to hear any thoughts on that now that we can take back to our group. Donald, are you on the call?
Dean, I'm on.
Great. Do you have any thoughts about prohibiting the sale of sugar-sweetened beverages in terms of the environment in which our military personnel live and work?
It's an interesting. Of course, it's from our perspective, from a population health perspective, it's a great concept. It's kind of the same thing of restricting the sale of sugar-sweetened beverages in supermarkets and, fast food restaurants. And so it's something that's worthy and would be impactful, but the ability to implement it would be as challenging as it has been, because we would need a really good reason to single out the food and beverage industry to prevent their, ability to sell their items in stores, commissaries, and fast foods and other locations. And so while I agree it's a great idea from a policy perspective, just as you know how difficult it is, and even just making the argument to do that, because those decisions in the departments
are outside of health. Those decisions are in those parts of the agency that control space and location and have those logistics responsibilities. And healthcare providers within our department don't have the purview to make that decision, which makes that an extremely different. It's just like the tobacco argument, but only much more difficult because we know what tobacco is associated with. We're trying to make the same recommendations for a beverage and to isolate that beverage as the sole cause for diabetes and obesity would be the challenge that has been there for some time. Over.
Do you foresee that challenge being, is that unique to military settings, or do you see that as, because we recognize that challenge as it relates to federal government-owned or leased offices, et cetera. We also recognize there are circumstances in which people are living, their residence is actually is federally owned, so we would need to be careful not to, to make sure that people can consume those beverages if they so choose to purchase them somewhere. But do you believe that the restriction, if it were accepted, that the military should be exempt from that?
It's a tough point because even using tobacco as an example, the department's moved away from separate pricing for tobacco products just because someone's on an installation or can shop on an installation. So similarly, because 70% of our service members live off of the installation within their communities, and they take on the characteristics of the health characteristics of those communities they're living in. So it's going to be just as much of a challenge. And if, like I said, if you use tobacco as the example, with all of the successes we've had with price point, you may have to look at taking those same approaches with sugar-sweetened beverages to look at pricing initiatives so that they're still available, but just you disincentivize or you incentivize other more healthier beverages. Those approaches may be more effective, but I think it is similar both in the general population, the civilian population, and in the military.
What is the current policy around tobacco sales in the military bases?
Current policies are to equal the prices in the general population, so not to have the lower prices. Sales taxes are the same. Prices are matching the market, and that's changed within the last couple of years, and so that's been a long time in the making.
Okay,
but
so
currently, if you go on,
there's no prohibition on the sale of tobacco?
No, it's not. No prohibition.
It's not discounted anymore.
Thank you. That's correct. And that took some time to get to that point.
So is there any downside to banning the sale of sugar-sweetened beverages on military bases then? I mean, so it would be difficult to do, but would there be any adverse health effects or harms of doing that?
Yeah, I definitely don't think it would be a problem to eliminate them from a health perspective, because someone drinking a sugar-sweetened beverage is not getting any kind of health benefit to it. But I think in a free commerce society, to eliminate the product, as we all know, would take is a tougher hill to climb. To say, well, that product should be banned, that's a legal product in the country for sale. So I think most of the efforts in the department are to focus on those smarter, wiser choices for fueling those individuals who see themselves as the warrior athletes, and to take that mindset of the training table mindset and providing those choices. But then there are, places to go to get as much sugar-sweetened beverages and, sugar-sweetened foods as you want. So it boils down to the individual choice and the training requirements that help to maintain the fitness levels. And as our service members age, as they become less physically active, then they succumb to the same issues we have in the general population.
Yeah, is there the way this is this is a question, the way this is currently written, is it likely to be ignored and nothing done, versus writing it as disincentivize the use? And I'm just wondering about whether this will be wholesale ignored the way it's written versus a disincentive.
And are you responding, was that Sherry?
Yeah, sorry, this is Sherry, and I'm just responding. I'm actually thinking more about the federal prisons too, and like personal rights.
Right,
and what you're allowed,
right,
you know.
right.
So
yeah,
I
guess I'm asking, are you responding to the general recommendation or to specifically the inclusion of the military in the prisons?
I guess I was thinking more about the military in the prisons. I'd have to go back and think more about just, I think that's where I've been thinking more than the other.
Right, I mean, the difference, of course, being, I mean, the prisoners are incarcerated, so they don't have the option to go off campus. And in many regards, many military members are also, you know, they've dedicated their lives to X number of years to that employer, if you will, as opposed to someone who works at the CDC office or someone who works at the Department of Transportation who comes and goes in and out of work. That's one issue. The other issue is that in the former cases, I mean, they're their employer for life, right? I mean, it's the military is their employer for life in a way, and so that the argument could be made in either direction because we bear the cost of their health care. But certainly, in terms of the liberties that people have, it would differ if you're in the military and if you're in the prison system.
Well, I wonder if it makes sense to distinguish HHS agencies here and other federal agencies.
Hi, this is Sunday. I think that might be important. I'm quite uncomfortable with the idea of banning something that, especially when you talk about the military and folks in the prison system. You know, part of this has to do, and the reason I'm uncomfortable with it is the issue of choice. I think it's a tough balance that we have to think about, balancing people's ability to make that choice versus the health benefits. Ultimately, choice has to be first, actually, because the right to choose, in my opinion, is outweighs the potential health benefits. And denying someone the right to choose is a bigger issue to me than the potential health consequences of them consuming sugar sweet beverages.
So let me just make sure I understand the point you're making. Does the right to choose mean that one has to sell the product at a workplace versus I have the right to choose to drink sugar sweetened beverages? I'm going to go across the street, or I'm going to go down the street, or when I'm at home grocery shopping, I'm going to buy my sugar sweetened beverage and I'm going to bring it to work to consume. Is that your concern, or is it the concern around the people who really don't have the liberty to choose because they are beholden to the environment in which they are working or being incarcerated?
Number two.
Number two, okay.
This is Meredith. I'm remembering all of the furor that came with the free living people in New York City when they were being told that they couldn't get the large size sugar sweetened beverages, and just all the lobbying and the excitement and so forth. So I'm just wondering there too about what could be done about disincentivizing as opposed to not making it available. Maybe even working with the people to offer if they, I'm not sure if this is getting through. It says my microphone is being turned on. But in any event, just adding my voice to the disincentivizing as opposed to not allowing.
Yeah, so I'll remind folks that we do have another recommendation that we presented last time around excise taxes on sugar-sweetened beverages, much akin to tobacco, although to a much smaller extent. So the idea is the combination of taxation plus ban of sales in particular settings, in this case federal government settings as well as in public schools, would work synergistically. But again, I mean, this is why we're here. We're putting this draft recommendation before you to see if there is agreement that, at least with respect to the non-military bases and non-federal prisons, whether having the federal government sites not sell sugar-sweetened beverages is a recommendation we can get behind.
And Dean, this is Jennifer. You have a comment from Howard in the chat. He says he was thinking that pricing might be easier to implement.
Yeah, I'm sorry, I don't see it. Could you read it?
Yes, he says he was thinking pricing might be easier to implement.
So just Howard, just what everybody else has been saying, that incentivizing, disincentivizing might be easier to implement from a practical point of view, what Don was saying and what Meredith was saying, rather than ban.
And for implementation, are you referring to the political feasibility or the logistic implementation?
The feasibility, really.
From an acceptability standpoint.
Right, correct.
So this is Bill Herman again. Though I do think that HHS agencies do want to send a health message, and I think it might be more palatable to ban their sales through HHS agencies.
So you're saying restrict it to HHS as a sort of a model federal department?
Yeah, or at least give some more thought to that.
Yeah, this I think that would be. I'm more comfortable with that than all federal.
Yeah, this is Sherry. I guess I'm thinking also about the public, because you said the public school systems, and I think that I don't know what the challenges would be to implement that within public schools, but that seems like a good place to do that as well, since kids can go elsewhere to get sugar-sweetened beverages besides the school system. It seems like if you're sending kids to a school system, it should be free of sugar-sweetened beverages. But right. So I would be all for prohibiting it in schools if we think that that will fly as well.
Yeah, this is again.
Yeah, and that's what Aaron had presented. Aaron had presented previously to do that by incentivizing schools by backfilling the revenues that they generate that provide essential school services. Somebody else is going to mention something?
Yeah, this is I was going to say I'm in support of banning it, limiting access in schools as well. Where I was drawing the line was all federal.
Right, you were supporting the HHS. You were supporting the HHS idea that Bill put forward?
Yes, I supported that, and I also support public schools.
Terrific.
Dean, we're going to need to have you finish up in about 10 minutes.
Okay. Do we have enough on this one, Bill, to move on?
I think so.
Thank you. Next slide. Thanks, everyone, for that. Let me pass it over to Dr. Bill Cook, and maybe you could skip this slide and go right to the recommendation slide. To the next slide, Jennifer.
This is Bill. Can everybody hear me?
Yeah.
Great. Yeah, I would go right to the recommendation. In the interest of time, we sort of went through most of these recommendations, but we kind of decided to reword the second bullet point here, and this is regarding the IRS's incentivization. So the recommendation would now read, the IRS further incentivize developers to place new housing units in areas of low poverty, as data shows that moving people from areas of high poverty to low poverty favorably impacts the prevalence of obesity and diabetes. It was just clunky the way it was worded the last time, but we can certainly put it out as is now for any discussion.
Hi, this is Bill Jung. I have a question about the additional piece of it. So the idea is that by increasing the availability of housing in low poverty areas, you can get people to move to those areas. Is that thinking?
Yeah, it's based on the data from the Move to Opportunity experiment where they took people from high poverty areas where there was a lot of poverty and put them in public housing that was located in areas of low poverty. And the people that were housed there prospectively did better with regard to obesity and developing diabetes than those who remained in areas of high poverty. And that's the thought process, is based on that data.
Okay, so I think what the piece that I was missing when you were reading through it was sort of the concept that it was affordable housing for people to come from impoverished areas to low poverty areas.
Yeah, like do you mean to say to place new public housing units?
Correct.
Yeah, I think it's a wording piece because it's confusing. Would that solve the problem for the, I don't know who else was talking right before me, but if it said to place new public housing, would that resolve that?
Yeah, Sherry, this is Bill Chong. Yeah, I was the one who raised that question. I think that additional sort of adjective would help.
Yeah, I think it would be to be aligned with HUD language. It would be public and or subsidized housing.
Right.
So we would reword it, the IRS further incentivized developers of public or subsidized housing to place new housing units in areas, et cetera, et cetera.
Correct. I think actually, Bill, if it's developers you're talking about as opposed to the federal government, it's all subsidized housing.
Yeah, these are the people that are using these tax credits that are coming through the IRS program.
Correct.
And yeah, so
it's
all
subsidized.
Yep, that's right. Okay, so I'll add that in and send it over to Jennifer to insert, if that's okay.
Great.
Yeah, thanks,
Thank you.
Bill. Appreciate it. Good suggestion.
Next slide, and one more slide. So you recall that last time we were talking about the synergistic and deadly effects of the combination of tobacco smoke exposure and diabetes in terms of the significant elevation of risks of death when one combines both having diabetes and being exposed to tobacco smoke, either firsthand or secondhand smoke, as well as the negative consequences in the general population of being exposed to tobacco, and the evidence suggesting that tobacco exposure itself contributes to incident diabetes as well as its diabetes complications. And so you may recall that the HUD currently has a smoke-free policy in its public housing units, and we had made a recommendation that and a recommendation that aligns with the CDC's Office on Smoking, which would be to expand the smoke-free policy that currently exists in public housing to multi-unit subsidized housing. That is multi-unit buildings owned by private landlords that offer, that the federal government offers subsidies to low-income people to live in, to rent, essentially. And so we had recommended that the HUD broaden implementation of these smoke-free policies to include subsidized multi-unit housing. Go back, please don't move. And a concern had been raised as to whether or not an unintended consequence would be an increase in homelessness because smokers would be evicted for breaking the smoke-free policies. We have reached out to experts in this field, both at the CDC and in academic centers that are studying this question, and they recommend the following as a means to address this concern. But again, we're putting this before you to see if this is adequate or not. So the first is that HUD should, as it does with its public housing units, require that subsidized multi-unit housing have designated outdoor locations for smokers' use, so that there would be nearby a place where residents of housing, of subsidized housing, could go to smoke if they choose, and that HUD HUD's work in this regard would align with the related policies in public housing so as to ensure that loss of housing is not an unintended consequence, and work with the CDC Office on Smoking and Health so that an appropriate public health approach is taken. What I've learned is over the last 10 years or so since smoke-free policies have been instituted in public housing, a very small, on the order of, you can count on one hand, people have been evicted from public housing, and it's always been because, it's not because of the smoke-free policy, but because of additional ways in which the tenant broke HUD rules, and this breaking of the smoke-free policy was added on to a number of other infractions leading to eviction notices. So apparently the smoke-free policies in play at HUD public housing do not in and of themselves lead to eviction initiatives towards eviction. And I've asked from the CDC Office on Smoking to receive the HUD policy as it relates to public housing so we can get greater clarification. And I recall that I think it was Iotunda had some concerns in this regard, as did a couple of others, as did we, our own group.
Yeah, that's correct. I did have some concerns about that as it relates to creating and having unexpected or inadvertent consequences that could be worse than, I mean, not being homeless is a lot worse than risk of developing diabetes.
Or heart cardiovascular disease or what have you, yeah.
Dean, this is John Boltry. How effective is this? I mean, do people actually stop smoking because of that policy?
Apparently, it's extremely effective, and I can share some papers in this regard, primarily as a result of the reduction in secondhand smoke to those who are non-smokers. There also have been demonstrated reductions in smoking among smokers, but the major health benefit relates to the dramatic reduction in secondhand smoke exposure to the 70% of people who aren't smokers in the building.
Thank you.
So is this is again, so is this is an existing policy? How does
it is an existing policy in public housing owned by the federal government, and the question here is, should that policy be extended to HUD's subsidy program, in which federal dollars are given to subsidize rent on privately owned multi-unit housing facilities that house low-income HUD subsidy recipients, which is about half of the HUD program.
Well, but based on the data that you presented, I'm far more comfortable with, it looks like the experiment has been done. And if, in fact, the data is showing that people are not being evicted as a result, and in particular, there seems to be a huge benefit in terms of reducing secondhand smoke, then I would support extending it into the rest of the program.
Great. Any other comments, concerns? Okay, let me move quickly. Bill, do I have a few minutes to review the research recommendations?
Yeah, if you can, a couple of minutes anyway.
So we have 4 recommendations for research that relate to our subcommittee. The first is that NIH should increase funding to support large-scale natural experiments research, including cost-effectiveness analysis, to inform the evidence base related to social and environmental policies that prevent and control type 2 diabetes. I will say that NIDDK currently has a small program that has funded a handful of natural experiments, but what we're recommending is that this be increased. Particular focus should be paid to so-called health and all policies types of interventions that are also relevant to non-health agencies' activities and to other public health non-clinical interventions. Second, we recommend that the NIH should expand its initiative, please go back. There we go, should expand its initiative on we need someone to mute. Should expand its initiative on precision nutrition, which currently focuses on primarily the microbiome, to include trials that can inform critical population health questions related to which foods, beverages, ingredients, and additives promote or prevent the development of type 2 diabetes. Should include studies of communication interventions and counter-marketing practices to inform which practices work best for which subpopulations with respect to changing dietary patterns, and expand the definition of precision to go beyond targeting the individual to including targeting geographic entities such as high-burden neighborhoods. Next slide. We also recommend that the NIH should also support, in collaboration with other agencies, research to better understand the role of exposures related to environmental toxins, contaminants, unclean water, on metabolic function and diabetes risk, and extend its research on life course trauma, on metabolic function and diabetes risk and associated interventions. Further, we recommend that CMMI should support demonstration projects in collaboration with non-health agencies related to influencing the social determinants of health and reducing diabetes risk and improving diabetes control, such as what we've described with the USDA and SNAP, housing interventions, EPA and fresh water, etc. Relatedly, that we engage USDA, EPA, Department of Transportation, FDA, etc., to fund research into how their policies and practices might affect diabetes risk and could be changed, and if, when, and if they're beneficial, amplified to better prevent and control diabetes. And finally, to support research training investments needed to be made by the NIH and CDC to harmonize databases and enhance the workforce skilled in the competencies needed to carry out robust simulation work to inform health impact assessments. I failed to say this harmonized databases should be deleted from this recommendation. This is really a workforce training recommendation to help create the workforce to carry out robust health impact assessments. Comments or questions or feedback?
Hi, Dean. This is Bill John. I just wanted to clarify a piece about the maybe on recommendation A. Are you asking Congress to provide more funding to NIH to fund these research initiatives, or is it you have NIH redirect its current funding to research these areas?
Right. Can you go back to recommendation A, Jennifer? Yeah. My understanding is it's not in our purview to make that distinction. So this will be reworded to say more funding should be provided to enable NIH, more funding is needed for NIH to support large-scale natural experiments research, whether that is within the budget of NIH or is appropriations decision. My understanding is that that is outside the scope of our commission.
Okay, thanks, Dean.
Great. Thank you very much, Dean. I think we should move on, but I thank you and your subcommittee. That was great. We're running a bit behind schedule, and I'd like to propose a revision to our schedule. We do have one individual scheduled for oral public comment. I'd like to go to that now. And then I'd like to postpone the discussion of the format for draft recommendations. There is one slide that will circulate. But then after the oral public comment, I'd like to give an update on the work group on health system level interventions, the first couple of recommendations from that group. So Jennifer, do we have anyone online for oral public comment now?
Yes. Professor Joe Thomas is.
Okay. Professor Thomas, then we'd like you to give your brief introduction, and then you have 3 minutes to speak to the Commission. We thank you for coming on today.
Yeah, good afternoon. I'm Professor Joe Thomas. I'm the head of the School of Public Health at the MIT World Peace University, and I'm speaking from India right now. Thank you for inviting me to make a verbal public comment during the 10th U.S. National Clinical Care Commission meeting. Let me acknowledge the contribution of the Commission in highlighting the issues of health equity and diabetics. The Commission should pay more attention to the global dimension of the health inequity due to diabetes. 422 million people worldwide have diabetes, particularly in low and middle income countries. And today we know that diabetes is one of the leading causes of death in the world. The global prevention efforts, data on social determinants of diabetes could contribute to the domestic policy and program efforts in the United States. The Commission is meeting under the shadow of COVID-19 pandemic. COVID-19 significantly impacted the health services for diabetes. The impact is global, but that low-income countries are the most affected. The Commission's deliberations and recommendations have a global dimension as well. The global commitment to reduce diabetes includes meeting Sustainable Development Goals, which calls for the reduction of premature death from non-communicable diseases, including diabetes, by 30% by 2030. In this context, my recommendation to the Commission is the Commission should pay attention to the intersectionality of COVID-19 pandemic and diabetes. The Commission must develop a mechanism to integrate the global dimension of diabetes into the Commission's recommendation. The Commission may develop a mechanism to address the global health burden of diabetes, particularly the gestational diabetics of women in developing countries. The Commission must develop a mechanism to work with U.S. Secretary of State, U.S. Agency for International Development, and U.S. Global Health Ambassador's Office. Thank you for your attention.
Thank you very much, Professor Thomas. Very good points.
At this time, there are no additional public comments, Bill.
All right. Thank you, Jennifer. Then I'd like to go on to an update from the work group on health system level interventions. This work group has had a number of calls with key informants and has prepared 3 reports addressing health insurance and access to care, making medications affordable, and service delivery and payment models to improve care for people with diabetes. We'll be circulating these reports to the members of the Commission in the next week or two to review. The reports themselves include extensive background information, discussion of the problems, and draft recommendations. But today, just to begin the discussion, I'd like to focus on the preliminary recommendations related to health insurance and access to care and making medications affordable. So if I can have the next slide, yeah. So health insurance impacts access to care and health outcomes for people with diabetes. The health insurance system in the U.S. is pluralistic with 4 major sources of health insurance: employer-based coverage, marketplace health plans, Medicaid and state children's health insurance programs, and Medicare. This patchwork system has left substantial numbers of Americans uninsured, though the Affordable Care Act addressed some of these gaps in insurance coverage, though many clearly remain. With respect to access to care, I'm going to present draft recommendations focused on 3 areas: employer-sponsored health insurance, marketplace health insurance coverage, and Medicaid coverage. Clearly, workforce issues and health literacy are also important to access to care. Those topics are being addressed by other subcommittees, and I'm not going to discuss them today. Next slide. So the first recommendations relate to employer-sponsored health insurance coverage. And here the issue is that there are what are called Cadillac plans that have rich benefit packages with first dollar coverage and high deductible health plans offered by employers that really require substantial deductibles before insurance coverage kicks in, and then require substantial patient cost sharing. To try to address some of these disparities, there are three recommendations. The first is to limit the tax exclusion for employer-sponsored health insurance to a dollar amount equivalent to a silver marketplace health insurance policy or a good health insurance policy without necessarily all the bells and whistles. The second recommendation is to remove the tax penalty for employers that do not provide employees with qualified health insurance coverage, but to require those employers who do not provide employees with health insurance coverage to provide sufficient funds to the employees' health reimbursement accounts to cover the cost of silver marketplace health insurance policies for those employees, their dependents, and their children up to 26 years of age. So these first three recommendations really are aimed at improving coverage of employer-sponsored health plans and to address some of the disparities among the coverages. The
Bill,
second set of
Bill, I'm sorry, could you define what silver marketplace policy means relative to the Cadillac plan and high deductible plan?
Yeah, so there are different levels of insurance under the Affordable Care Act that can be purchased on the marketplace. A high-level silver marketplace plan would have what would be considered very good coverage. So there's, I think, gold and silver and bronze levels. So this would be a very good insurance plan. Okay, can we go on to the next recommendation? And the second recommendations really apply to marketplace health insurance coverage. And here the recommendation is to expand that coverage to make premiums more affordable under the marketplace and to stabilize premiums so that they're more consistent from year to year. A number of these recommendations actually have been recently addressed by executive orders from President Biden, but as Carol had pointed out, I think to formalize the recommendations would be important moving forward. The first is to restore funding for advertising and consumer assistance for marketplace plans and to increase the enrollment period from 30 to 90 days. The budget for advertising was severely curtailed over the last 4 years, and the enrollment period was also cut back. They need to be restored to where they were. Second would be to establish special enrollment periods for individuals who lose employer-sponsored health insurance or whose incomes change dramatically during the year due to changes in employment. Again, in recent years, special enrollment periods were curtailed for marketplace plans. For people whose circumstances changed, they need to be liberalized again. And third, cost-sharing reduction payments should be restored for individuals with incomes below 250% of the federal poverty level who are still not eligible for Medicaid. The cost of marketplace insurance plans is a major driver of whether people elect to enroll or not. And for low-income individuals, it's very important to have some cost-sharing reduction payments so that they can enroll or that they choose to enroll. In addition, premium tax credits should be provided to individuals with low incomes below or between perhaps 250% and 500% of the federal poverty level who do not have employer-sponsored health insurance, so that they can also purchase health insurance through the marketplace to make those plans more affordable. Fifth, to give states the authority to auto-enroll subsidy-eligible individuals into marketplace plans, provided that the premium is less than or equal to the amount of the individual premium tax credit. So some people, lower income people, receive premium tax credits but elect not to enroll in marketplace plans. This would get them into health insurance plans. And finally, to establish a federally funded and state-administered reinsurance program to cover high-cost individuals enrolled in marketplace plans. One of the problems with the cost of marketplace plans is that a few high-cost individuals can really impact the financial stability of the plans, and this reinsurance program would help keep premiums more affordable. And the final focus of this access to health insurance is really improved access to Medicaid, which is the topic of Medicaid expansion to the 11 states that still have not chosen to expand Medicaid. One of the problems is that the federal match rate now for states expanding Medicaid has been reduced, and so one potential solution would be to provide financial incentives by offering a 100% federal match rate to states that expand Medicaid currently to individuals with incomes less than 138% of the federal poverty level. So provide an incentive for those 11 states to expand Medicaid. And failing that, to consider subsidizing marketplace private insurance for all low-income individuals who currently fall into the coverage gap between what state Medicaid will cover and where people can get subsidies to buy their own health insurance. The median percent income in states that have not expanded Medicaid for Medicaid eligibility is about 51% of the federal poverty level. So in those states, there are substantial numbers of people with incomes between 51% and 138% of the federal poverty level who are not eligible for subsidies and are not eligible for Medicaid in those states. Another barrier to expanding Medicaid from the state perspective is that there is some concern that the long-term federal match rate may change. And so if the federal government could explicitly guarantee the match rate, it would reduce states' concerns about their financial liability if they expanded Medicaid. And finally, one of the issues that occurs currently in Medicaid is Medicaid churn. People gain and lose their benefits from month to month. And a potential solution to this would be to offer continuous 12-month eligibility to adults who enroll in Medicaid, even if there's a change in income during the coverage year. So once people are in, keep them in for a year, even if their income situation changes. So those were the draft recommendations related to access to care, which is really access to health insurance, and again, addressing the 3 of the 4 major sources of health insurance. The 4th is Medicare. That actually works pretty well in terms of access, though there are other issues with it, more related to service delivery and payment models. But I'll pause here and see if there are any comments or questions.
Bill, this is Carol. The number 4, under recommendation 3, I certainly have had patients who $1 more and they're off and $1 less and they're on. But I've also had patients who were on Medicaid who became employed, had a good income, and had other options for health insurance. So would you say that's just the cost of providing that safety, the safety net underneath someone with Medicaid? Or I just know how much states struggle with some costs.
Yeah, I had not thought of that. I think that that's a good point, and we would need to, I'd like to get your thoughts on that, whether there'd be some way to address that in this recommendation.
Yeah, it's a lot. I mean, I've had people who've had CHIP, and the mom makes literally $1 more, and they're off CHIP, and they didn't even know it, and they had a bout of DKA and had to pay the 100% of the cost, that type of thing. So I really am familiar with the problem. There needs to be an out somewhere to protect the state as well. So thank you.
Yeah, good, thank you.
Yeah, I agree. I think the Medicaid recommendations are very strong. I mean, the Carol's concern notwithstanding, I think these are great, Bill.
Good, thanks, team.
So, Bill, there is a comment from Sherry in the chat. She says, do we think that politically a national health insurance plan, Medicaid or Medicare for all, would not occur if we recommended that?
Yeah, so I have elected to approach this as an intermediate step, building on the existing system rather than repeal and replace or Medicare for all. I just don't think that there's the national will for either of those options now. I could be pleasantly surprised, I guess, by Medicare for all, but again, what I've tried to do is work within the existing healthcare delivery system to make recommendations to plug the gaps in coverage within the existing system. I obviously don't have all the answers on that and would welcome other people's thoughts. Sherry, I don't know, is that what you're recommending, or what are your thoughts?
Well, I don't know if there is appetite within the commission for that, but and certainly politically is a whole question. And I guess I wonder, though, if there's appetite within the commission, I guess I'm wondering if we should recommend it, and then we could certainly recommend the other options as choices to make if people don't go that route. But it feels it feels like we could make the recommendation whether we think it's going to be taken up or not. But I wouldn't take away the recommendations you've listed here. It just was something that that strikes me, that if we're really trying to improve outcomes, that that the real way to go is a national health insurance plan, in my opinion.
I think, yeah. Can I comment? I think, Bill, this is Dean. I think we are beholden to present evidence-based recommendations. I mean, unfortunately, unless we look outside the United States, we don't have the evidence that a national. I happen to believe that a national health insurance plan would be great, but we don't have the evidence that would provide superior outcomes. We do. I think we can very clearly say, in terms of the what we recommend, that every American have adequate health insurance coverage, we could, and the evidence supports that in terms of diabetes outcomes, I think we could state that there are many ways that this could go, and that our recommendations have focused on the current structures as they exist now. And I guess the question before you is, Bill, is would we then need to make a recommendation about any new structure, or at least comment on a different structure than what we have now?
Yeah, so I thank you very much for that. I think that's helpful. The underlying principle is that every American should have access to affordable health insurance coverage. And in the background for this document, I basically discussed that. So let me circulate. I'd welcome a discussion on this. Let me circulate the draft paper, and I would also welcome more input from other members of the commission, that we could actually kick this around and think about it more.
Yes, this is Meredith. Just one very quick question. As we do discuss it more, these are excellent recommendations. We can't give good care without insurance, et cetera. But my question is, we're talking about every American versus, are we intending to make this diabetes focused at all? Or is there any risk that by making it very, very broad and hence very expensive, that we might ultimately undermine something that we might have been able to attain if we spoke just about diabetes? I'm thinking, for instance, in terms of medication costs, where diabetes medications, particularly insulin, are just a terrible situation, and everyone knows it to be so. But that would just be my question. Should we be, this is just a completely open-ended question, should we be making recommendations for all Americans, or specifically for people with or at risk for diabetes?
Yeah, so actually the next topic I'm going to discuss is making medications affordable specifically for people with diabetes, so do take that perspective. I'm just not sure that we can recommend a national health insurance program for people with diabetes. I think that would not be palatable necessarily to the general public. So I think in terms of health insurance coverage, we do need to take a broad perspective. I think for making medications affordable, some of the recommendations apply to the general population. Others apply simply to people with diabetes. And one of the limitations there is the anti-discrimination statutes, which really prohibit making some services or medications cheaper for some people than others, and I do think we need to address those.
Thank you.
Okay. Let me move on then to the second part, yeah, so making medications more affordable. As was mentioned, prescription medications are really essential for preventing and managing diabetes, its complications, and comorbidities. And a lot of policies that have been implemented to contain medication costs have adversely affected appropriate utilization of medications, especially among low-income individuals with chronic conditions like diabetes. So these draft recommendations are focused on 4 areas. The first is ensuring the availability of generic medications. The second is controlling the cost of brand name medications. The third, increasing the transparency of the pharmaceutical distribution system. And then fourth, which is what I just mentioned, is reducing regulatory barriers to value-based medication pricing. So the first recommendation is really to keep prices in check and medications affordable for people with diabetes, by encouraging robust competition by generic medications. And here the recommendations are that the Federal Trade Commission and the Food and Drug Administration should ensure that generic drugs are available and inexpensive by first limiting pay for delay arrangements to curtail anti-competitive behaviors. And this is where brand manufacturers actually pay generic manufacturers not to bring their medications to market. And the second is closing loopholes. There's a 180-day exclusivity period given to first-to-file generic manufacturers. And so there are cases where generic manufacturers get this 180-day exclusivity period during which they can bring their drugs to market, and then they don't bring the drugs to market because they're encouraged not to by the brand manufacturers. So this would require a reasonable justification for any delay in bringing a generic medication to market to start the 180-day clock on the first to file exclusivity. The next slide relates to the issue of the cost of brand name medications, and basically the drug approval system is designed to reward manufacturers for innovation, but at this point that needs to be balanced against unnecessary barriers to competition. So here again there are recommendations for the FDA to again ensure that drug discovery incentives are adequate but not excessive. And here the recommendations are, one, that patent laws should be modified to discourage manufacturers from applying for multiple patents on a single drug and from making slight modifications to old drugs to obtain new patents to extend a drug's exclusivity period. Two, shadow pricing for drugs with few manufacturers should be curtailed. And as I think many of you know, this was the case with insulin glargine and insulin levemir. The prices increased multiple times over time in lockstep with one another. The third recommendation is that market exclusivity for biological drugs should be reduced from 12 years to 7 years, and unnecessary barriers to biosimilar market entry, including patent extensions, should be curtailed. And finally, incentives offered by the Orphan Drug Act should be removed for mass-produced drugs initially developed for common conditions that are subsequently repurposed as orphan drugs. The third set of recommendations relate to transparency in the pharmaceutical distribution system. There's a huge difference between the list price and the net price of drugs, which really reflect rebates and discounts negotiated between the parties in the pharmaceutical distribution system, including wholesalers, pharmacies, pharmacy benefit managers, and insurers. And these rebates and discounts are given basically to influence formulary placement. The repercussion of this is that high list prices disadvantage patients who pay the list price or pay coinsurance based on the list price of the medication, which is true in Medicare Part D. So we recommend greater transparency and simplicity in pricing to eliminate the distortions related to these rebates and discounts that are really beyond the reach of any individual payer to address. And the fourth recommendation relates to reducing regulatory barriers to value-based pricing to better align the price of drugs to their benefits. And there are a number of regulatory barriers to to value-based pricing that are in place and a number of potential solutions. And I think these potential solutions need to be explored in greater detail. One is simply value-based pricing, where the formulary placement of a drug and or its cost to patients is inversely related to its health benefits. So a life-saving medication like insulin would be available at zero copay or zero out-of-pocket cost to patients. The next is indication-based pricing, where the price of a drug depends on which disease it's being used to treat. Some drugs like Viagra may be used for erectile dysfunction or for primary pulmonary hypertension. The price for a lifestyle medication should be different than the price for a life-saving medication, even if they are the same drug. Another potential solution is drug licensing schemes, where a manufacturer sells a license for a lump sum payment that entitles licensees to an unlimited supply of the drug for a fixed period of time at zero or very low cost. This is another potential way of making life-saving drugs available to more people at low out-of-pocket cost. And finally, an intriguing recommendation has been money-back guarantees, where drug companies provide refunds for patients who try a drug but see no clinical benefits. This addresses some of the formulary restrictions and the low uptake of potentially revolutionary drugs. For instance, some of the ultra-fast acting insulin analogs, they've been marketed at a premium price. It's unclear as to whether they actually have much value in terms of outcomes, or whether the price is justified in terms of the benefits. A money-back guarantee could increase the uptake, but limit the financial liability for some of these new drugs whose value is not clearly known. So those were the recommendations related to making medications more affordable. Some, again, are general, and some are really specific to people with diabetes.
Bill, this is Carol, and I understand a lot of the pricing problems around orphan drugs, but the example of a mass-produced drug for a common condition then found to be useful in a rare condition. Is there an example in diabetes, and then does that then raise the cost for every condition, or only if it's used in that rare condition? I guess I'm trying to apply it to diabetes, and I know my brain's tired, but could you help me with that one?
So I've kicked that around as well. It was an issue that came up in the literature. I'm not aware of any, and I think actually if we can't come up with an example of either something that's out there or something that's in the pipeline, we should probably drop it because it doesn't apply to the diabetes to follow Meredith's recommendation. Yeah, so if anyone can think of an example, let us know. Yeah, go ahead.
Yeah, Bill, this is Dean. Does the value-based pricing recommendations, would it include the ability of, let's say, Medicare to negotiate for lower prices, or is that a separate set of recommendations?
No, and that is one of the issues there, that there is that prohibition. So yeah, that would be part of the recommendation.
So is that embedded here, or does it need to be made explicit?
No, I think you're right. I think it does need to be made explicit. So federal programs, and there's different ability across programs to negotiate prices, Medicare Part D versus the VA versus others in terms of their ability, and that needs to be expanded.
Dr. Herman, this is Bill Chong. I was wondering if you could flip back to recommendation 2. I just wanted to clarify a few points with respect to the, So my understanding is that the incentives for drug discovery were those were outlined by Congress. FDA doesn't sort of dictate, like, we're going to change it to X number of years exclusivity now. So just kind of to clarify that point. FDA also doesn't play any role in patent law. So as refining the recommendations, just wanted to clarify those pieces.
Good, thank you. That's actually very useful.
Dr. Herman, this is Bill Chong again. And with respect to the first one on the generic drugs, I'm going to do a little bit of digging, but I believe there's already some things in place to try to prevent sort of people from, I think there's a forfeiture where people can forfeit the 100-day exclusivity for generics, but I'll have to double check that.
That would be explained. That would be great. Yeah, Bill, I'd like to involve you in the future discussions of these. Those are all excellent points. Good. Anything else on this now? I know it's quick, and I know that you all haven't really had a chance to reflect too much on this, but I want to bring this back again. And as I said, I would welcome anyone who's interested in these topics to engage. We will be scheduling some work group meetings after we circulate the papers describing the background and the problems and the revised recommendations. Good. Moving on quickly, do we have, we were going to talk about the format of our recommendations. We don't have time to do that. I want you all, though, to just look at this. This was a recommendation for how to format the recommendations for the final report. I think personally that this is somewhat limiting. This came up today in terms of how much background needs to be provided. But think about this, and we will schedule a separate meeting to discuss this and certainly bring it back at our next commission meeting. So at this point, I think we should close. The next steps, I think, are to continue refining the recommendations and adding new recommendations. In the next week or two, we would like each of the subcommittees to put together the recommendations that they feel are final enough to solicit public comment on them. I think that we may only have an opportunity to put our recommendations out there for public comment once between now and the time we need to complete our report to Congress. So I would encourage all of the subcommittees to put forward their recommendations, even if they are not final, so that we can get robust comments on them. We're going to try to do that within the next couple of weeks. So I want to keep, again, the momentum going that we've established at this meeting, and really try to move us on to beginning to write our report. So with that, I will end and pass it back to Jim for closing remarks. Oh, just one other issue. We do not have yet a date for our next meeting. Please be on the lookout for the next meeting announcement. So that remains yet to be determined. So Jim, do you want to adjourn the meeting?
Yes, certainly, Bill. Yes, thank you, everybody. I really want to let you know I was really be impressed with the recommendations and the passion that this group had as the advisory committee. With that, as a designated federal officer, I'm closing today's the National Clinical Care Commission Federal Advisory Committee meeting. Thank you.
Great. Thanks, Jim, and thank you, everybody, for your attention.